much, Tara. That was very kind for that introduction. I just want to say a massive thank you to all our speakers that have come today and everyone that's come to listen. Myself, Stephen and Greg have had several weeks trying to put in some good work for this, so I'm really looking forward to it. I think it's going to be a really good couple of weeks. So I don't know if Greg or Stephen wanted to say anything just before we started. Or if not, well, I will. Oh, Stephen's going to say something. Go ahead, Stephen. Okay. So we're going to start the day, and I'm going to invite our first speaker, who is Emma, one of the ST3s, to talk to us about period problems in teens. Thank you very much, Emma.
Hello, so I've just unmuted myself. Can you all hear me now? Wave if you can. Great. Okay. So hang on a second. Have you allowed me to share screen? Yep. Great. So I'm Emma. For any of you that don't know me, I'm one of the ST3s about to see CT in a mere 2 weeks, which is very exciting. But I've been asked to talk to you about period problems in teenagers. I chose this picture really because I think this is how some teenagers can sometimes feel when thinking about their periods, like somebody in one of those life rafts, overwhelmed and out of control. And what we're hoping to do is to try and improve that for the young people that we see. So just a bit of an overview about what I'm going to talk about. So I'm going to start with thinking about how teenage period problems are different to adults and the nuances you might want to think about when you're consulting with a teenager. I'm going to talk a bit about period poverty. And I want to then think about the impact that your young person's periods might have on their quality of life and the importance of having an awareness about that so that you can try and help. We're going to talk about amenorrhea, by specifically not including dysmenorrhea, because the treatment really is the same for an adult woman. There's no real changes there. I'm going to talk about heavy menstrual bleeding or menorrhagia, a little bit about postponing periods, and then any questions I can try and answer at the end. If anyone's got any questions as we go along, I'm very happy for you to butt in, or if you try and go on the question. Sorry? Oh, or if you put it in the chat function, I might try and notice or somebody point it out to me. Okay. So first of all, teenagers, what's different? Well, with regards to periods anyway. Teenagers. So when you start your reproductive life, so when you start having periods, your body doesn't produce eggs in a regular fashion in the way that somebody in the middle of their reproductive life does. And that's the same as you get to the end. I think a lot of us will be quite familiar with the older woman who's approaching menopause, who comes in saying the periods are irregular and heavy and they've been bleeding for 10 days and then not again for 6 weeks and then bleeding again for 2 weeks. And that's generally because of anovulatory cycles, so cycles where you're not producing an egg. But we also see that at the beginning of your reproductive life, and teenagers will often come and see the GP worried that that's abnormal, that there's something wrong, or that there's something wrong with their body, or that they're not going to be able to ever have children, which seems to be a frequent concern if you sort of dig a little bit. And sometimes all that needs is reassurance that this can be normal. It's your body getting into a cycle. It doesn't start off straight away producing regular eggs, and that can be okay. In an older woman, so somebody who is 48, for instance, who comes to see you with heavy periods that are going on for longer, you're more likely to be required to investigate because there's always a concern about endometrial cancer or endometrial hyperplasia or fibroids, those sorts of things. These are vanishingly rare in teenagers. So in general, we don't need to investigate or examine these young women, which is good because they don't want that. The other thing to think about is, does the young person in front of you need contraception as well? I'm not going to talk about contraception because I know it's being covered by somebody else, but I suppose what I'm saying is to bear in mind that some of the young people you see will need contraception as well, and that's a separate issue, and you're almost opportunistically being able to help them by bringing it up when you see them. But there will be a small number of teenagers for whom they come to see about their period problems because they're wanting to talk to you about going on the pill, which they actually need for contraception, but they don't want to tell you about that. And I'm not saying to be cynical or to not believe the young person in front of you, but just be mindful that sometimes people struggle to bring that up. And if you don't ask, you don't know. And equally, if you always ask when mum's in the room, you also might not know. So I would always say, oh, you know, I always want to ask all young people I see a couple of personal questions. Can you step outside the room, please, mum? You know, that's on the basis that you've got somebody in your room, which in these days you don't. You might be on speakerphone, so that's a little bit more tricky, but there's still ways to navigate that. The other thing I want to talk a bit about is about the impact that period problems can have on a young person's schooling, education, their sport, and just general their social life. Well, when you have a social life, not at the moment. And you can't underestimate that. These are young people that are trying to get ahead with their education, trying to find their way in the world. And what we really don't want is for any young women to be held back by their periods. A recent survey showed that the average teenage girl in the UK misses 3 days of school because of period problems. I think that's rubbish, absolutely rubbish. You know, we've got huge discrepancies still for earnings and education for men and women, and period problems aren't helping this. So anything we can do to help address that is great. And I've got a few pictures here. Just thought this might, oh, sorry, there, to think a little bit about sanitary protection, just because there's a few things that changed a little bit over the last 10 years, and people might talk about things you might not know what they are. So on the top right, I think most people will recognise that. That's a tampon. On the bottom left, most people will recognise those. Those are sanitary pads of various different descriptions. Bottom right, so this is something that's really come in over the last 10 years or so, and is generally the preserve of older women. But I have seen some teenagers that have used them, or spoken to some teenagers that do use them. So this is a moon cup. This is a sort of a flexible latex or rubbery cup that sits inside the vagina, collects menstrual blood, and is then emptied. And they can be handy for people with larger and sort of heavier flows, because they do contain more than a tampon or a sanitary towel. But in general, they're not so popular with teenagers, but just to bear in mind they do exist. And on the top left, ostensibly looks like a pair of pants, you might say. But these are increasingly popular, particularly with teenagers. These are period pants. So these are pants which absorb menstrual flow and can be really effective, particularly as a backup option for a young woman that's worried that their tampon or towel might leak and it might go over their uniform and people might see it. It's a bit of a backup option. They are expensive though, so do bear that in mind. They are sort of £15 to £20 a pair, which is extortionate, but hopefully that might improve. Okay, and thinking about that as well, a lot of the concerns that young women may have is about leaking, and leaking it being on their school uniform and people seeing it being laughed about. And again, that's a stigma really. That's an ongoing societal stigma about not talking about periods, which again is something that I think needs addressing. So moving on, just thinking a bit about period poverty. This has been increasingly in the news over the last sort of year or two. There's been a big government task force about it, because 1 in 10 girls in the UK still can't afford sanitary products, which is shocking really, absolutely shocking. And again, some of this feeds into some of the stigma, because a lot of girls, so 68% of girls in a large survey felt unable to concentrate at school when they had their period. And some of that is because maybe they were uncomfortable, they had some period pain. Some of it is concern about leaking and somebody knowing, or people might know they've got their period. And some of it might be because they're unable to afford period products and they've got some underwear that's stuffed with tissue paper or socks or whatever. And that might sound ridiculous, but it's really quite common now, for it just being a household expenditure that can't be afforded. And there's a load of charities that have, small scale generally, charities that have sprung up to try and address this. And these have reported a 5-fold increase in demand during COVID. Wanted to sort of let you know about the Department for Education period product scheme, which is great. So this came in last year in January, whereby all schools in the UK, all youth groups, can request sanitary products for the young women under their care. And that's not just there's an emergency supply for someone who forgets them. That's for any sanitary products they might require, and they can request that the schools can order those free of charge. So if you come across a young woman who is struggling to afford sanitary products, it's worth letting her know that she cannot get these from school or college if she needs to. But of course, if schools are closed, then they can't access these. And a lot of women were getting their sanitary products from food banks, which increasingly have been closed during COVID, or struggling with reduced donations. So it's a big issue currently. Moving on, I wanted to talk about primary amenorrhea. So this is when you have no periods at all before the age of 16, or no periods before the age of 14 if you don't have any secondary sexual characteristics, which in the main part means breasts or pubic hair. Let's move that. So the differential really, if you've got normal secondary sexual characteristics, that's a young woman who's less than the age of 16 but has got breasts or pubic hair. It includes genitourinary malformations, so that might be, so there's some unusual midline malformations where there's an absent vagina, or it might be an imperforate hymen, or endocrine problems, and this can be thyroid dysfunction or prolactin problems, and obviously other weird and wonderful things, but sort of grossly speaking, those are the sort of things to be thinking about. Differential if there's absent secondary sexual characteristics, remember this is before the age of 14, would include primary ovarian insufficiency, chromosomal causes, of which there's an enormous list, which we don't need to be aware about as GPs, but to remember Turner's syndrome, which is quite common, and hypothalamic pituitary disorders, which there are again some weird and wonderful causes, but can also include things like excessive exercise and eating disorders. So, huge differential. What sort of things are you going to think about asking the young woman in front of you? So you're going to be thinking about, are there any signs of androgen excess? Does this young woman have acne or voice changes or male pattern alopecia? How much is she exercising? Is this somebody who's, I think the term is exorexia, but are they a competitive athlete? Are they unduly stressed? Have they got any discharge from their nipples? Is there a visual disturbance? So something suggesting a prolactin tumour, a macroprolactinoma. Are they unusually short? Could they be pregnant? And of course, you'd be unlucky, and it's unlikely, but you could get pregnant if you're sexually active before you start your periods. If your first cycle produced an egg and you were sexually active and sperm met that egg before you'd had a period, you could get pregnant. Very unlikely, but not impossible. If you don't think about it, it'll be missed. So what baseline investigations would we do? So generally it's sort of hormonal screen and think about thyroid, checking thyroid function. There's a list there. And you might not remember that list, but so CKS is really helpful. Oh, sorry. So CKS is really helpful here. It's got a really helpful list of investigations and go-to things to think about. I encourage you to look at that when you, if and when you see a young woman with this. So we're going to refer as GPs all women with primary amenorrhea, and where you refer them probably depends slightly where you're working. In Sheffield, Peds Endocrine will see them. It also depends slightly on their age. I saw a young woman recently who was 16, and I wrote to Peds, and they decided, it was an advice and guidance email, and they decided that gynae would see her. But I think if it had been a younger woman, less than 16, they might have seen her themselves as a first off. So a little bit tricky to know where to refer, but if in doubt, ask. You can always pick up the phone and ask, or email and ask. This is a reminder to think about Turner's syndrome. It's actually quite common, 1 in 3,000. So at your average practice, you might have one, and sometimes they're not diagnosed a little bit later. And then this young woman's got some quite classical features of Turner's syndrome, but sometimes they're not very obvious. Okay. Secondary amenorrhea. So this is also quite a common thing to present with. This is no periods after established cycles, which is generally considered to be within the first 2 years. And of course, for most young women, their cycles won't establish very quickly. And it may well be that the young woman who comes to see you ostensibly with secondary amenorrhea is actually just sort of settling into her cycles and needs a bit of reassurance. things to think about would be eating disorders. And of course, remember, young woman in front of you may have what looks ostensibly like a normal BMI, but may be massively restricting her intake. If you don't ask, you won't know about that, and that needs to be handled sensitively. Maybe somebody exercising excessively. Stress can suppress your hypothalamic pituitary axis, stop in periods. Systemic illness, any systemic illness. And of course, PCOS is equally as common in young women as well. Going to move on to think a little bit about menorrhagia, or what we now call heavy menstrual bleeding. In general, this is grossly similar to adults, the treatment, other than when you're seeing somebody for the first time, it's important to think about, could this be the first presentation of a coagulopathy? So it's worth thinking about those other questions we think about with a coagulopathy. So, have you ever had a dental extraction? Did you bleed a lot afterwards? When you cut yourself, does it seem to take a long time to settle down? Do you bruise more than other people? Has anyone in your family got any bleeding problems? It may well be that perhaps there's haemophilia in the family, so that there's a tendency to bleed in there. In general, these women have less indication for an examination. We're less concerned about thyroids, we're less concerned about a malignancy, so hopefully we won't need to do a PV. All young women should have a full blood count checked if they've got heavy bleeding, all. You're even more likely to be anemic as a young woman because you're probably still growing, so there's a heavier demand on the body from that perspective, more likely to have iron deficiency anemia. And a lot of teenagers don't have the best diet, well, a lot of adults don't, but teenagers in particular. So after thinking about investigations, think about what treatment can offer this person. And first line would be medical treatment, and probably non-hormonal to start with. And the recommendation usually is to start with either NSAIDs, and we used to use mefenamic acid frequently, but this is of course blacklisted now in Derbyshire. So for instance, either naproxen or ibuprofen, or tranexamic acid. And then alternatively, thinking about hormonal options, I think most of us go to, initially it would be the combined pill, if we felt it was safe for the young person in front of us. And, so that would be thinking about a VTE risk in general. And you can use the UK MEC to guide you, but of course the UK MEC is written for contraception, not for medical indications. So, but it is helpful as a aide-memoire for all the general risks, factors that you want to think about. So previous history of VTE, the overweight, history of breast cancer, which is unlikely, isn't it? But liver problems, etc. Alternatively, you can think about using a progesterone-only pill. Wanted to remind you that, of course, you can use a coil, so a hormonal coil, intrauterine system such as a Mirena or a JDES in teenagers. There are still people out there who say that it's not possible to fit a coil in an nulliparous woman, which is not true. I fitted a number of coils in nulliparous women, and actually they've all been very straightforward to fit. So it shouldn't be an option that's withheld from young women. With the caveat that I think I wouldn't want to fit one in a woman that wasn't a teenager that wasn't sexually active. Gynae do this if medical options are failing and somebody is very distressed with their heavy menstrual bleeding, in the same way that we will do for a woman with learning disorders, but it's generally done under a GA, and that would be something I would be referring to Gynae or talking to them about. Wanted also to remind you that if you're worried about fitting a Mirena through a nulliparous tight cervical os, there are other coils available now, including the JDES, so it's the one in the middle at the bottom. It's tricky to see from this picture, but it's a narrower diameter coil, so they're easier to get through a tight cervical os than a Mirena. That's an option. However, it's not licensed for heavy menstrual bleeding, although we do know that it does help. Okay. And then wanted to move on to thinking a bit about postponing periods. And generally this is something that is quite common on the on-call list, or comes up if you're a duty doctor in the summer holidays. And people think about going off on lovely holidays to nice beach destinations like this, which of course nobody is doing at the moment. But regardless, I suspect probably when we're all allowed to go again, everyone will be queuing up and wanting to not allow their period to ruin their beach holiday. And some people will say this is a lifestyle thing and actually maybe we shouldn't be getting involved in this. That's not my viewpoint, but that is some people's viewpoints. And there'll be also some people that will say, well, northisterone is not licensed in under 12, so I'm not giving it to a child, essentially. And of course, everyone's entitled to their viewpoints and you must practice in the way that you feel safe. But I would say that if you are old enough to have an adult woman's body that is giving you adult women's problems, such as bleeding, then you're old enough to be given treatment to help with that. So it doesn't ruin your first beach holiday with a period and having to not worry about wearing a swimming costume, etc. And so I wanted you to think about who would prescribe something, so northisterone or Provera, for an 11-year-old going on a summer sports camp who was concerned about, not being able to get to the toilet because they were going camping, etc., etc. I don't know how well this is going to work, but I was hoping maybe we could do a bit of a show of hands. So, and you can press the little hands up button. Who would prescribe for an 11-year-old going on a summer sports camp with no risk factors or other problems? So if I get your hands up. Can you put a hand up, if you would? Okay. And who wouldn't? Okay, so there's a bit of a mix there. I can't see very well actually on my screen, but please hope it's got you thinking a bit about it. I would, and I think lots of people would feel comfortable doing that, but it's something that's worth thinking about. So the options for this really are northisterone or Provera, which is medroxyprogesterone. Increasingly, people are more aware that northisterone is actually partially metabolized to estrogen and hence has a prothrombotic risk. And so it tends to be contraindicated in a young person with liver disease, history of breast cancer, history of VT or PE. And it's approximately equivalent to about 50 mics of estradiol. So it's similar to, say, giving somebody microgynon. And hence, if you wouldn't give them microgynon, don't give them northisterone. So the way to give it is you generally think about starting it 3 days before the anticipated day of your menstrual cycle. And of course, there will be some women who won't know when that's going to be, and that's a little bit trickier. I normally say to just start it then, in which case as soon as you think your period's is starting. And you take it 3 times a day until it's no longer needed, and then they tend to have withdrawal bleed. Alternatively, in women who you think are higher risk and you're concerned about the possibility of VT risk, the alternative is Provera, which is unlicensed, but 10 milligrams TDS is considered to be safer in these young women. And that's the end. So has anyone got any questions for me?
Just a question, Emma, regarding the northisterone and Provera.
Yeah.
And for how long do they usually take them?
So it sort of depends on the situation. So usually until bleeding is acceptable. So if you're going on holiday for a week and you thought you were going to start your period, say, on the Saturday, you would start using the northisterone 3 days before you were anticipating your period to start, and then stop taking it when you got back.
All right, thank you.
I've got a quick question, Emma. It's just about a patient that I've been seeing. She's 12 years old, and ever since I started in August, her mum's been phoning sort of every month because she's been having heavy periods and also really painful periods. We've tried pretty much everything analgesic wise. She's on codeine. She's perfectly well before, like, when she doesn't have a period, and it lasts about 5 to 7 days. We've put her on the pill and that's not helped either. So we've requested an ultrasound scan. She's not sexually active, and just to make sure there isn't something else. Examination is normal, and we've suggested sort of continuous pill rather than having the pill-free period. But at like what point do you think that there might be something, like if the ultrasound comes back as normal, do you think she would warranty a adolescent gynae referral? And I think that's kind of sort of where we're heading towards, because I don't really know what else to do with her.
So is she having heavy and painful withdrawal bleeds still on the pill?
Yeah.
I think,
But she's taken a 7-day gap. She's not. So in that 7-day gap, she's having a heavy, yeah, exactly the same. It's not made a difference.
And I think, have you tried, so you said the next thing you're going to try doing is try cycling or the extended regimens.
Yeah.
That would be the next thing I would think about doing. And then if you're not getting anywhere there, I think it comes to the end of the road of what we can do in general practice. And I think you're right, and that's talking to gynae, isn't it?
Yeah.
She might be a young woman that maybe would benefit from a Marina.
Yeah, I think it's just because she's 12, so
she?
young, and I don't even know if it's just kind of that she's only just started a period. So whether it's just that adjustment time, it's sort of at what point do you sort of say, well, actually, this isn't really normal anymore, and
which is worse as well, the heaviness or the pain? Because if it's the heavy bleeding, then you could try tranexamic acid. Did you say you tried?
Yeah, we've tried that, and mefenamic. I know that I didn't realise that wasn't licensed in Derbyshire, but we've tried that as well. So, so none of it's really helped. But yeah,
I think it's a tricky one. I think that's probably a bit of advice from peds gynae.
I agree. Trying the pill back to back sounds good. The other thing you could think about is a depot, because that usually puts them in amenorrhea anyway. And I suppose what you need to use is your experience of the family. Is this a really stoic, sensible family, or are they all a bit pathetic? Because if they're all just a bit, oh, I've stubbed my toe, I need an X-ray, then actually you need to be a bit more, get a grip.
Yeah.
I don't know if I can say that, but Tara, I can't see Tara anymore, so I think it's okay.
You might not be able to see me, Mark, but I can see you. Can I interject for a moment, guys? I'm mindful. I'm getting a lot of messages saying people are trying to get in and can't because we're at 100. So people were asked to RSVP today to go on a list. Now, I've taken people on trust that if you're here, you were on the list. But it's clear we agreed that the list was stopped at 94 to allow some of our presenters to come in early, and the fact we're at capacity and people who officially had places haven't managed to get in. I know this is a really useful, important teaching session, but that's why the invitation went out, and it was very clear, first come, first served, and many fewer than 96 people had registered, because we then opened it up to say that some trainers and associated people could come. So I know you might say this is always our teaching, but the emails made it very clear that you did need to RSVP for a place. I'm about to have a look through the list that I've got from Nicole about who RSVP'd. And I'm afraid if you are here and you are not on Nicole's RSVP list, you will be removed from the meeting to let somebody else in who did reply to the email. So if you know that you didn't RSVP to Nicole and you're here, please find it in yourselves to go now, because actually it's not fair on people who have planned ahead and booked study leave to do that. And obviously it's going to be a real issue if some of our presenters can't actually get in to present. That would, that is a big deal. So as I say, we're now down to 99, so one more person should be able to get in. But as I say, if you didn't RSVP and you are here, you're going to need to leave, I'm afraid. And yeah, back over to Emma for the last little bit of questions before the next person does their presenting.
I have one question.
Okay, go ahead.
Yeah, so I know that it's to delay the periods, but it's not going to affect the ovulation. Yeah, is that correct? This is what I understand that. Because ovulation has occurred before, and then it's your now the period time that you are delaying by starting northestrone or progesterone 3 days earlier than your period date. So, for example, if somebody falls pregnant on the next cycle, so what will be their LMP? Will we count it from the day that was expected, or from the day when they actually had the periods?
So you're preventing the withdrawal bleed. So at that point in your cycle, you would have anticipated that you've already ovulated. When it comes to thinking about the LMP, I think you would have to go, well, I think it's going to be a bit tricky. I don't know if you would go on the date when you anticipated.
That was actually the start.
I'm not
when
sure.
You anticipated it. Yeah, okay.
It's kind of irrelevant, because you'd be roughly within the right date anyway, I guess. you're thinking about dating a pregnancy. I don't know, has anyone else got any ideas?
I'd ask the question, why isn't this person on contraception if they're needing it? Because northisterone isn't really a contraceptive. You know, I'd say get them on something else, because people are silly, you know, and I think if there's any chance they could be getting pregnant, as in they might be going on holiday to meet somebody, I'd say get them on the depot or something else then. You know, you don't really want them just on northisterone.
No, if they, for example, if they're not on contraception, I'm not talking about contraception. I'm saying that if somebody is not on contraception and they just asked for, like, we are going on holiday and we need that to delay the periods. And on the next, like after they came back and they got pregnant. So the LMP will be that one or the previous one?
I don't think it matters. It's still within 4 weeks, isn't it?
LMP, yeah, the LMP will be decided according to the first scan.
Okay. Thank you.
I'm just thinking as well, when you were saying about sort of using the depot, I know that there was one occasion where I agreed that was appropriate. Well, had no other way. It was the only viable option, but obviously there's a risk of osteoporosis. I've known it called mood disorders. You know, some people can get very depressed on it. Obviously you don't want to miss a dose, so it can be. I just wonder, for me, that would be a big choice to make, to use that in a young woman, or, you know, young women frequently, just because of the risks further down the line. If they say, yeah, this is great, this is the one I'm going to use, you know, a long time, and obviously there's, you know, I think at one point it was certainly when I was growing up, it was you know, great, everybody thought it was terrific, but I think subsequently down the line, because we've got other options when it comes to contraception, it's I don't know, obviously you're keener on it than I am, perhaps.
I think it's getting a balance, because I know where I work, you know, if I've got a 13-year-old who's having sex, my biggest worry is them getting pregnant, and then the risks and then the issues with that. So, you know, again, I don't go around depoting everybody I can find, but there's certain people, you know, I know if they're going to be a terrible pill taker, they're not yet on board, at least it gives you some time to kind of protect them pregnancy-wise. Obviously, there's a whole other issue if they're having sex at age 13, but I work in a pretty rough area, so that's my main concern, you know, first off. And yeah, I'll worry about the osteoporosis and getting them off the depot later, and that's a pain in itself, but I'll probably get them onto an implant then. But
yeah, I was going to say that would be what I would.
Yeah. So again, I'm not going to say I'll deafen them for years and years, but I just say, you know, if they're coming in and you go, damn, I've not got a lot of time, damn, they can't even take a tablet, what else are you going to do? I'm not going to get an implant the same day. So it's trying to be pragmatic, I think. But I'm probably a bit, you know, it's pretty rough where I work, so I'm a little bit, you know, I'm a bit parental sometimes.
I was going to ask as well about endometriosis. So I imagine it's harder to pick up in this population. Apart from obviously referring them to gynae, is there anything that you think can, because obviously irregular periods, irregular bleeds, painful periods, it seems to be trickier. And I certainly know sort of a family friend who, she had it very young and it's in her bladder, and she's had awful problems later on down the line, probably because it wasn't diagnosed earlier on. So if Emma's or anybody's got any suggestions.
Well, the combined pill is quite a good treatment for endometriosis, isn't it? And regardless, so, you know, these young women are likely possibly to end up taking a combined pill for symptomatic control anyway, and that should help from an endometriosis perspective.
And in terms of sort of, if they can't take the combined oral contraceptive pill, would you go down the line of a POP? And is there any particular ones that you prefer to use?
Oh, I prescribe Cerazette. I don't ever prescribe the traditional ones anymore, just because I think, well, who can remember to take it in a 3-hour window? So
yeah, absolutely.
If somebody's on them, continue it, but otherwise I wouldn't ever start it. I don't know if anyone else does. Does anyone else prescribe Noviday? Right.
Okay.
I've got a quick question, if that's okay.
Guys, would we be able to move on now? Because we've got quite a packed evening. That was a brilliant chat though, Emma, and lots of talking points. But next up we've got Dr. Mark Graham, who's a Chesterfield qualified GP with a special interest in dermatology. He's going to be going through that for us today. Okay. Thank you.
Can I just remind you, if you're not speaking, you need to have your microphone on mute, because otherwise it jumps to you and it's really distracting for the presenter. So please make sure that you are on mute unless you are Mark. Thank you.
Hello, can you hear me? Can you see me? Can you see a nice screen? Yeah, good. Okay, so I've been introduced, so we're going to talk about some acne, some eczema, a bit about warts, a bit about ingrowing toenails, and then have some questions. And if you've got any questions, you can put them in the chat, you can raise your hand, you can speak, whatever you want to do. We'll do questions at the end anyway, but whatever works for you is cool with me. Right, so skip the page. So when we talk about acne, we need to think about what lesions we're looking at, and we can kind of think about papules, little sorts of lumps. We can think about closed comedones, whiteheads. Think about blackheads, which are open comedones. They're really the same thing. They're just sort of full of kind of keratin and sebum, and it's just the oxidation that turns it from white to black. We think about pustules, which are kind of more sort of pussy. Whiteheads are ones you really want to squeeze, and they've got inflammation around them. And then nodules, big lumps, and then cysts, which are kind of part of that, really. Let's have a look at some pictures. So let's think about severity as well. So yeah, in terms of severity, kind of we think mild. There's not much going on. It looks mild. You just go, it's mild. I think about severe. There's nodules going on, and then moderate somewhere in between. There's lots of scoring systems you can use, but I just think looking, going, how much is there? Where is it? And thinking about that really. Right. So pictures. So these are papules, as we can see. Let's see if I can draw. We can see sort of little lumpiness bits here, and this lady's got quite a bit there, just sort of little lumps on the skin, not too much to worry about. Here we've got some blackheads, lovely blackheads, don't we like blackheads? And we've got some, probably more getting into pustules here. And everybody all eaten? We're not feeling sick, are we? Good. And then looking more, this lady, it's very papular, isn't it, here? Got a couple more inflamed looking ones. This chap's not having a good time. He's got some really sort of very inflamed lesions. Hard to say with these. Are these kind of nodules, or are these more kind of keloidy scars? That one's a bit excoriated as well. And then these, I'd say these are worse. I'd say this is kind of, moderate severe. This lady's got lots going on, lots of inflammatory pustules, just all sorts. And this person the same as well. This chap, not great, is it? And then kind of nodules. So these are clearly nodules. We've got a big lump there, got some big lumps. That's not good. I kind of want to see those in dermatology. And then thinking about what we get after acne, so we can get scarring. We can get ice pick scarring, which is like somebody's kind of chipped into the face with a pick. And this is kind of similar. This is probably more post-inflammatory change, as in there's been kind of the inflammation there, and that's what we're left with. And seen on darker skin, so we do get pigment change as well, and this is post-inflammatory hyperpigmentation. It's due to inflammation. That will get better with time, but we'll talk about that in a bit. And then also we can get keloid scars. They're more common in people of Afro-Caribbean origin, but anyone can have them. I had a guy, I think he was probably on roids, if I'm honest. He got some really nice keloids on his chest. And they kind of look different to our nodules because they're kind of firmer and they're not pussy and they're not inflamed. They're kind of post, really. So what treatments do we want to go with? So as a baseline, we want to wash with some soap. Good, easy for girls, maybe more difficult for the boys. There is some evidence about foods with high glycemic index. So it used to be when I was young, it was all don't eat chocolate, don't eat chips and things, but probably it's more to do with kind of high sugar things. So chocolate, cakes and things along those lines possibly make a difference to spots. So reducing that might help. Smoking, we know, does make a difference, and stopping and reducing smoking will make spots better. And also think about PCOS. There's probably some link there. I'm probably going to treat it the same, but it's just worth thinking about, have we actually got, a whole thing going on here? Are the periods not quite right? Is the excess hair and other things as well? So this is from the Lancet 2012. The short answer is things haven't really moved on in acne for quite a number of years. We're still working on European Consensus 2014. I think we might get something soon. So just think about what to use, and that's why I want to describe the lesions, because if we're kind of mostly comedones, sort of mostly sort of the black or whiteheads, we want to use a topical retinoid because that seems to be most effective for those. So that's adapalene normally. If it's mostly pustules, sort of the inflamed looking white head type things, we want to use benzoyl peroxide. And with the benzoyl peroxide, actually, which one? Just go for the 2.5. You can give the 5 or the 10, but there's not a lot of evidence it's much better, and it stings a lot more. So yeah, stick with 0 and 2.5. If they really want to go hardcore, go for it. And if they've got a bit of both, give them some combination treatment. So what are those in real terms? So benzoyl peroxide, adapalene is the retinoid topical I use most often, and then DUAC is benzoyl peroxide and clindamycin. Or Epiduo, I quite like that. It's benzoyl peroxide and adapalene, so I quite like that one. The other thought as well, it's a little bit contentious. I'm not sure I feel about it, but we know when we give people oral retinoids, we've got to get them on contraception because oral retinoids are teratogenic. There's a suggestion topically might be an issue, so you know, we kind of don't want these people to get pregnant. I think it's more of a theoretical risk than a true one, but it's just something to bear in mind. So if we give that a go, if it's mild, if it's not helping, we go to a combined preparation. If that's not helping, then we want to go for kind of step 2. I don't really use a lot of alzaic acid. I don't find it very helpful. You can give it a go, but it's doing the same thing as the benzoyl peroxide, really. So if things are moderate, or they're not improving with below, or it's very widespread, so if it's all over the back, the chest, and the face, they probably want to think about oral antibiotics. And generally, we can use limacycline or doxycycline, and we kind of want to go for 3 to 6 months of either, and we tend to see the most benefit at that time. In addition, and always and, never just always and, we want to give them topical as well, and we want to give them topical retinoid or topical benzoyl peroxide. Why? It's more effective. It reduces resistance, so it works better for longer. So yeah, go with that. In ladies, think about the combined pill. Which one? Any's fine. There's some people think Yasmin is better. I tend to go with that if sort of the first line is not helping. And then Dianet, I don't prescribe that very much anymore. That's supposedly more effective, but the evidence is it's more risky and is much better. It's a tricky one. Oh, I should say as well, you don't need to make any notes because I've got some QR codes so you can just screenshot in a bit and you'll get all the guidance and things. So we'll come back to that. But yeah, key point, always topical and oral together. Don't choose oral because they'll come back and they'll say it's not working. So, and if that's not helping, well, they probably want to come and see me in dermatology or a real dermatologist. And that's if we've got nodules going on, if it's really scarring. But if you are going to refer them on, please get something started. You know, if they wait 3 months to see me and they've not had anything, you know, they've just scarred 3 months for no reason. So get them started on something. And then the other kind of criteria is not improving with 2 lots of antibiotics, so limacycline and then doxycycline for 3 months each. Other kind of general pointers. So, oh, I've gone the wrong way there. Where am I? So don't mix oral and topical antibiotics. You're just going to increase the risk of resistance. So oral antibiotic or topical, you know, don't mix those 2 up. Under 12s, we're a little bit more limited in what we can do because we can't give them tetracyclines because of the bone risks and also the teeth staining. Mum's not going to like you if the teeth are all yellow. So we can give them trimethoprim and you can use topical things. That's okay. If you've got kind of quite widespread areas and you just think it's not possible to put on the benzoyl peroxide or the adapalene, just get them to do it once a week. You know, it definitely makes a difference, and you know that's better than nothing. Beware, I remember this when I was at Butter Lad in Yorkshire. Benzoyl peroxide stain sheets orange. It's a bit crap really. So I just say put on your One Direction t-shirt, whatever. Just cover your pillowcases so you're not ruining all your nice sheets. And then the general thought is if we give 4 to 6 months of oral antibiotics with a topical, as we all know, then we can just go back down to topical treatment, and theoretically that should then maintain things and kind of control it just with the topical. It's kind of what we want. I don't seem to get that working very often, if I'm perfectly honest, but it's worth a go. And just coming back to what can we do? So our kind of options are, we've got isotretinoin, Roaccutane, which is an oral retinoid, and we tend to go to 4 to 6 months. It depends what dose we can get them on. And after kind of 1 course, 50% are cured. Their spots are gone for forever or acceptable level forever. Some people need an extra course after that. There is this slight increased risk of suicide, so we have to kind of be careful, and obviously dermatologists are great at monitoring mood. But it's just being mindful of that. It's not clear really whether that is all to do with the the retinoid or whether it's related actually to the severity of the acne and the impact of that. I think it's probably a bit of both is the short answer. We need some baseline blood. So if you want me to get somebody started on isotretinoin on the first day they see me, if you get some bloods in, I'll be really, really happy and you get a lovely letter. Apologies if I've sent shitty letters out to people. It's one of my issues. And also women must be on contraception for isotretinoin. It's mandatory. It's not an option. They must be on it because the retinoids are catastrophic for pregnancy, and essentially if you're on a retinoid and you get pregnant, you have to have a termination. It's not a discussion. Thankfully not had that so far. And also there's a very dogmatic rule that the prescriptions for isotretinoin have got to be monthly, and they have to come in, do a pregnancy test, get the script and go. Even during COVID, we're still doing that. So just bear that in mind. If a lady's going to university, she's going to Glasgow in 2 weeks' time, she's not going to want to come back and see me, every month to get a script. So just bear that in mind where we're going. Somebody's asking, can patients be on top of antibiotics long term? Yes and no. So I think it's thinking about where we are. If they're 24, I'd probably get them referred along if it's quite bad, because by then most people it will have got better. So actually maybe they want to think about some isotretinoin for that. I'd rather than be on the combined pill if it's a lady, because that will help and there's not any worries antibiotic wise. You can use them long term. A couple of years is fine, balancing the risks of other things we're going to do, which is the isotretinoin. So teenagers, yeah, sort of 20s, 30s, just get them along to us. Other things we can do, we can inject steroid for keloid. You can put Dermavate on it if you want to. That's pretty good too. We sometimes use oral steroids if there's very sort of inflamed acne and things have been very bad, but I don't use that very often. We don't have any lasers. There's no lasers in Chesterfield. There's no lasers anywhere. We don't have any access on the NHS. If they want that, go and see privately. And generally my thought would be to do that after they're finished. There's not a lot of evidence it makes a lot of difference. And I don't do dermabrasion. I don't do peels. I'm not a beautician. No kind of thoughts of that as well. How long do you have to be off retinoids before conceiving? We think generally a couple of months is good. So ideally they come back for pregnancy test kind of a month after, and we normally say keep on the pill anyway because they might get some flares. So I'm answering questions as I go. We've talked about tips. So acne, if you want to screenshot this, so this is a nice summary on the GP update. There's a QR code because I am modern and stuff, so you can just bip that and it'll take you to it. If you want to see the full 2014 guidance, it's here. Sorry, you can't see my pointer. It's here. It's bloody long. Don't read it. It's like 100 pages of blah blah blah. But yeah, this is nice. Put it on your wall. It'll help. And make sure when you're thinking about what thing you're going to use, write in what thing you are going to use, because otherwise you'll be sat in a clinic going, what is that thing Dr. Graham said that's the combination? Are you going Duac, Epiduo, which one? So write them down and just remember which ones you're going to use. Answer that later in a bit. Let's talk about eczema. So I'm pretty sure you all know what eczema looks like, but if you don't, there's some eczema on some legs. Look, it's itchy, it's scratchy, it's red. Typical places, flexors, hands, face, generally, necks. Adapalene okay if on conception? Yes, that's fine. So eczema-wise, I'll do big questions at the end. So with eczema, get rid of soap. I don't care if it's simple soap, made of hemp, whatever. Throw it in the bin. If it's soap, which is sort of a oil which has been treated with caustic soda, essentially, which is what soap is. Anything with sodium lauryate sulfate in it, it's a detergent. It's going to pull oils out of the skin. It's bad. Get rid of it. You want to wash with a moisturizer, and that's really, really key. And they want to be moisturizing kind of 3-4 times a day. A lot of people, if they do that, their eczema settles down and it's under control and they don't need any more, which is good. Don't use Acres cream. Acres cream is bad. It should only be used as a wash, in which case, why are we prescribing it? It comes in a tub, you stick your hand in it, you risk sort of putting stuff in there and spreading it around, so don't bother with Acres cream. When things are bad, we're on a couple of weeks of steroid for flares. And which steroid? So hydrocortisone for the head, you can use Umivate if it's not kind of eye area. And then for the body, you want Betnavate, Mometasone. Or Metazone, and that's any ages. And when I say Betnavate, or Bethamethasone, I mean 0.1%, Betnavate RD, the 0.0025. It's the same as Univate. That's for orthopods and their nefarious purposes. Don't be wasting your time prescribing it. And none of this kind of up steroid, down steroid. blast it 1 to 2 weeks, stop it. If it's coming back and back and back, think about weekend therapy, using something twice a week. We're not doing this increase, decrease, because people just get confused and end up putting hydrocortisone on all day for 3 months. So that's the eczema we talked about. Are steroids scary? Anabolic are, they scare the crap out of me. Anything that shrinks testicles is awful. So skin thing is rare. I've seen it probably twice, and the one time was in a guy who got lichen planus on his sort of wrist area. So this is quite thin skin, and he's putting Dermavate on it for 3 months. I could definitely see he got some skin thinning, but lichen planus needs strong steroids. So for me, short bursts of potent steroids, 1 to 2 weeks and then stop, and then maybe weekend therapy, is less steroid overall than using hydrocortisone for weeks and weeks and weeks and weeks, and then not working, and then having some Umavate for weeks and weeks and weeks, and then some Fluclox that's infected. So if you get on with it, you'll get it better. And especially in children, young children, there's some thought, if you get it under control, you get the skin healed, then it might go away. They might grow out of it. And probably being aggressive in that treatment, even in 1-year-olds, is probably better than sort of tickling it with your 0.5% hydrocortisone. The steroid strength is related to where we're putting it, and it's kind of complicated. This drawing, the more I look at it, the worse it kind of gets, but it's a lot more complicated. But basically, you don't absorb much steroid kind of on the hands or on the feet. Groin and face, you absorb quite a lot because the skin's thinner, it's moister. Flex is the same, you absorb a bit more there, same on the axilla. So we're only really absorbing kind of 1% and even less on the hands and the feet. So we want to use a strong steroid on the body. Eczema eyelids, hydrocortisone, okay. I would say start off with an ointment. So it's an ointment emollient. So what could you use? Diprophyte ointment's fine. I'll show you the emollient formula later. So to start with that, go for a couple of weeks. And if it's not helping, yeah, go for hydrocortisone. The risk on the eyelids actually isn't too much about the skin thinning. The risk is there, but it's more to do with cataracts, because steroid in your eye gives you cataracts. So it's getting a balance. If they're getting persistent eyelid eczema, it's happening again and again, then actually it could be contact dermatitis, and maybe you want to send them to see us to do some patch testing to see, because normally we touch things, we rub our eyes, and that's where you get eyelid eczema. If it's just eyelids, then that's really strong. If they've got eczema elsewhere, it's probably more atopic. I know I've been quite vague about the eczema, but the point was just put some moderate steroid on it, get on with it, don't faff about. So really, for me, as we said, hydrocortisone on the hands is a moisturizer, and I say this to our trainees. So, if you put in hydrocortisone on the hands, well, what steroid are you giving them? And that's a very expensive moisturizer. Is there a risk of keratitis and ulceration for steroid on eyelids? Yeah, potentially, if you do it for weeks and weeks. It's more of a risk if you're putting the steroid in the eye, as in drops. So yeah, just be careful with it, but a good ointment there should hopefully settle things without the need for steroid. But a bit is fine. You don't want them to be really inflamed and getting periorbital cellulitis because they've got kind of infected eczema. Get on with it. Why so aggressive? Probably parenting maybe is why I'm so aggressive. I don't know. So with lymphatic eczema, we have itch, and then they scratch, and then the skin breaks, and then irritants get in, and that makes them itch, and then they scratch, and they go round and round this circle. And if you allow that to carry on, as we said, you get inflammation, you get thickening of the skin, and you get chronicity. If you get it settled, then hopefully it will improve and sometimes go away. Not always, because eczema actually is a systemic thing, and there's probably filaggrin deficiency and other stuff. So it's more complicated than that, but generally get on and treat it. If you sent them to me in dermatology and all you're giving them some moisturizer, you've not done a great job, doctor. So bear that in mind. Right, what's this rash? If you want to have somebody shout up or tell me in the chat, or smoke signals, whatever you want to do. Or rashes, it could be multiple things. So it's little papules, isn't it? We've got them on the flexors. Folliculitis. Keratosis pilaris. Keratosis pilaris is normally more on kind of the upper arms on ladies, and it's around the hair follicles. This is eczema on black skin. You're not going to see this a lot in Chesterfield. I didn't. I do a lot now in Nottingham, but it's really important somebody does show it to you, because it's not in many dermatology books. For some reason, we like pictures of white people. It's not really okay. So it's eczema, and on black skin, eczema is papular. It's like goose pimples. And kind of the key things with that is is being aware that's what it looks like. You know, these are typical places. We've got lichenification kind of going on up here. We've got pigment changes as well. And it can be really widespread, you know, and I often think you need to kind of put a hand on this to see it. I often get sort of, you know, young boys, and you kind of look from distance, you go, oh, it looks fine. You send the picture in, it looks fine. You put your hand on them and they're goose pimply all over it. It's like they've been in a sort of haunted house, and that's widespread eczema. We need to get on top of that. And I don't think we're very good at noticing this. I didn't used to be. I'm a bit better now, but it's just something to bear in mind. Yeah, so it's hard in the pictures. The best way to kind of get a good picture is get the parent to take sort of a picture with light angle from one side, and then you might see the bumpiness kind of more. And the pigment change, as we said, you can see there. And this is kind of, you know, we've also got the typical places. We've got neck, we've got back of the legs. Warts. Oh, I love talking about warts. I just like the word. So what are the rules about warts? So don't refer to dermatology unless you think it's a cancer. We're not apparently paid or supposed to treat them. I do what I want really in dermatology, because but you know, if it's really affecting things, it's like right into the thumbnail and it's just awful, I might do something, but we're not really supposed to. Well, you're not supposed to treat them. Apparently, it's one of those things they don't want us to be treating. So it's that sort of sending for over-the-counter treatment. Pharmacy first, if any pharmacists are still doing it. I can't seem to find any. And why? Well, you know, it's one of those things, it's sort of self-resolving, usually goes after a couple of years. And the kind of key things with warts is any treatment takes months. So when the parent comes in and says, oh, I've used Bazooka gel for a week, tell them to go away and come back in 2.5 months, because a week ain't going to do it. And they must scrape it down. I often see warts and they come in and they're like this tall on the skin. And, you know, half of it's Bazooka gel up here and then the wart's down here. But actually the wart goes under the skin there. And they need to kind of chop the top off and get it to there. You know, scrape it till it's sore and it's flat. And if it's not, you know, what you're doing isn't working. You're just painting it and making it taller with this Bazooka gel. So yeah, scrape them down. What do you want to use? Whatever. I just give people an option every time they come and see me to make them go and do something for a bit, because, you know, I don't want to do something with these. There was a time where I would, a couple of times during lockdown, I got really bored and I scraped off a couple of rucas and sort of cryoed them or cauteried them. But then the week after, everybody started hearing about this, and I had literally everybody and their mum coming in to do their toenails and visit for this, that, and the other. So yeah, leave them alone, because you don't want to get involved and start making you the chiropodist or podiatrist. These are links to the thing, so QR codes again and little URLs. You can use duct tape occlusion therapy, and that is essentially putting on a little square of duct tape on it, and you change that a week. It's all in the leaflet, and that's supposed to be quite good as cryo. Again, it's something to keep them entertained and be going on with. There's some evidence zinc tablets orally can be good for warts. I quite like that if they're a bit sort of wimpy and you can't get them to scrape it down. You know, so yeah, that's quite good. You can tell them to buy some pickles ointment from Amazon. That's 50% salicylic acid. It's the strongest thing you can get. I'm surprised you can buy it. It doesn't kind of burn through your skin. I tried it myself just to see what it's like on my feet, and not a lot happened. You can also suggest citrucidal, which is grapefruit seed extract. It's a little bit sort of homeopathic, but I've had a 50% hit rate of 2 people. One person, it seemed to clear them straight away, and one person did nothing. How exactly would you scrape them? So don't. But if you did want to do it, just get a scalpel and just kind of scrape the skin off. It's that simple. They can pumice it as well. You know, whatever they want to do. You can buy kind of from Boots. They've got these like scalpel blades for corns. It's got a little sort of thing on it. Try and stop you going in too deep. Either's fine. Warts on the face, yeah, I tend to just say oral zinc for that. It's something, if you've got access to cryo, I'd kind of look at more. I don't see that many on the face, but it's kind of as well, you know, if I've got a child and it's on the face, I could cryo it in dermatology, but are they going to let me? Because it does hurt, you know, so often I kind of think we'll go for the zinc with that, because if I'm not going to get near them with a spray, I'm not going to be able to do anything with it, you know, and there's not any other treatments we've got really. So yeah. Ingrown toenails. I love ingrown toenails. This was the other thing I spent lockdown doing. I did a couple of these, and then I was nearly the community chiropodist. It was awful. So beware when you get a picture sent in on your Acarex, whatever you're using, just beware if you get one picture and you say, oh, it looks okay, get another angle, because this is the key bit, isn't it? An ingrown toenail, it kind of curls and then it sticks in here and that's the issue. It's like a splinter in the toe. Here's some nice pictures. Lovely, so we can see that nail's ingrowing there. We can't see the gap between the nail and the edge there. Same here, so that's a really bad place to put the logo. We can see the edge of the nail is digging in, and there's inflammation kind of here coming, isn't there? So that's kind of the key thing. These I'm a little bit more suspect about. So if you see these, yeah, be a little bit more wary, because every now and then we hear about a case where a chiropodist's been treating this ingrown toenail and the hypergranulation for like a year, and it's just getting worse. So this on the left looks like overgranulation, but it could be a pyogenic. They think it's pyogenic on dermnet. I'm not sure I agree, but it's, you know, it's a bit of a big lump there, isn't it? And then I don't know what's going on here. I don't like that at all, this color change. I'm not sure what that is. But yeah, I don't like the look of that. You know, if it comes up in 2 days and it's indefinite ingrown toenail, give it some treatment. But if it's going odd, yeah, that worries me. Any thoughts on this one on the left and what's going on over here?
Melanoma.
Melanoma, yes, exactly. Why? So we've got a pigment here. We've got a little bit of Hutchinson sign where you get sort of pigment going into the nail bed. And this isn't ingrown toenail, is it? Because the toenail isn't ingrowing. It's just not happy here. So yeah, it's, again, I've never seen that, but it's one of the things that you go, shit, you don't want to be getting the referral in and the GP having sat on it for 3 months. Sorry, Tara, I keep swearing, I do apologise. Again, I work in a rough area, got to deal with it. So yeah, those I probably want to see. These kind of the same, don't like these either. So yeah, what's going on the left one? There's a lump there, isn't there? That lump's growing and it's kind of trashed the nail. You know, that's not an ingrowing, that's something different. It's probably an amylotic melanoma, don't like it. This one the same, the nail kind of is following here, isn't it? So actually the nail's not ingrowing, the toenail's just, this bit's gone all weird. So yeah, probably want to see that as well. So yeah, probably want those. Oh, and don't do an urgent referral to dermatology, please. If you get something you think it's a cancer, I don't care which cancer it is, do it as a 2-week wait. I've had a couple recently where it's urgent, and then for some reason somebody decides to send them to me as a telephone appointment at the hospital. So then I kind of playing, you know, guess who about this lesion. So if it's a lesion, it's a cancer, 2-week wait. You know, if it's melanoma, just 2-week wait, not an urgent one. Right, what we're going to do, so yeah, soak it in salt water. If they can kind of separate the nail from the skin, so if we think about the toenail there and they've got the nail growing, if they can get a bit of something like a bit of cotton wool kind of in this gap here to sort of keep it out of the way, that might help. You can give it some oral flucloxacillin, but the key thing is get them to chiropody. That nail needs to go. You know, it's like they've got a big sort of foreign body in the foot. It needs to come out. Otherwise, it's going to keep coming back and back and back, and you'll give them enough fluclox to kill a horse. So just keep going with it. Get them to chiropody. If you're scared, and we'll see, it needs to be done. There's not else you're going to do. It's going to keep going. So what about the impact? So I'm told there's a thing called TikTok, which is like FaceTiming, but not with your mum. And this is kind of about the impact on young people. So these are all famous people, I'm told. I don't know who she is, but she's on TikTok. I just Googled TikTok dancing. And what they all in common, they've all got great skin, haven't they? I can't see any spots, any papules, any nodules or anything going on. And Chris Pratt's looking good, isn't he? He used to be a bit chunky, but he's sort of muscly now. He's in the Marvel universe. And this is kind of the key. This is what young people are faced with these days. It was pretty bad when I was young. Probably I was young a bit of a while before some of you guys. But these people have got perfect skin, and people are posting pictures about themselves all the time and videos, you know. And I think this ideal of being perfect is even more than when I was young. So yeah, you know, so that's what they're faced with. And if we think about, you know, this in general, they've got this more pressure than we had because they've got it from the peers to be perfect. They got it from TV. They got it from people on YouTube, Instagram, TikTok, pornography as well. You know, there's a lot of makeup going on in there. And a lot of the Instagram, I get the impression with these influencers, whatever they are, I don't know, I'm a scruffy 30-something-year-old man, I've got no idea. But there's all these people promoting these products to get perfect skin, and there's kind of all this pressure, which then leads to unrealistic expectations. And that leads to unhappiness. And then that can be low mood. They can be missing school. I mean, not taking part in sport because of the horrible looking back, because of all the spots. Exactly, Elizabeth, I agree. It's unrealistic. I mean, you know, I think some of these, maybe not all Photoshop, definitely Kim Kardashian, definitely. But yeah, And I don't think people realise this, which is the issue. But, you know, there's lots of wide-ranging issues with this. And we know it can even alter people's life trajectory. You know, if you're really good at sport, but you don't take your shirt off to go and play football, then you're not going to do it. And then you're not going to, you know, be playing for England in 20 years' time. So it really makes a big difference. You know, and thinking about when we were sort of 10, 12, are you going to hold hands with this person? Are you going to want to be the boyfriend, the girlfriend? Maybe not. You know, you're probably they're going to get bullied for this. So it's important to think about and clear. Nasty eczema there as well. Get some mometasone on there, not the hydrocortisone. Good. You know, are you going to kiss this lady? She's got really quite bad acne. We need to get it under control. Or would you have Kim Kardashian? I know what I'd pick, but that's, yeah. I'm just thinking we've got the best evidences from psoriasis. And we know kind of, you know, psoriasis and the creams and that all the time, it does lead to low mood, it leads to poor body image, embarrassment, not wanting to partake in things, not wanting to go swimming, things like that, and avoiding relationships or people avoiding them because of this sort of horrible rash going on. And as you said, you know, that then sort of affects things. It affects your ability to attain your life goals. You know, if you don't want to do things, you're getting down and low, you're not going to school, then that affects things. If you're not going to pursue your career because that involves you being on Instagram and looking nice, if you can't do that because you've got a really scaly scalp, it's important. And also a lot of people, you know, with psoriasis, I think it's 20% said they worry about intimacy. And then that's a big part of relationships. So it does make a big impact. And just as a final thought, because people often think dermatology is like dead easy and like not important stuff. But I had this lady and she said, something on these lines. She got breast cancer. She comes in with this rash and said, "Oh, I can deal with the breast cancer. It's fine. But the rash is unbearable, doctor. I can't sleep. I'm sore. I itch. I leave trails of skin everywhere. People don't want to take money from me because my hands are so awful. The rash is worse. I'll die from the cancer, but I can't live with this rash, doctor. You need to fix it." And I was just blown away because I was like, you know, breast cancer doctors take precedent over me, this pretend dermatologist. But, you know, I think that kind of sums it up. Cool. Any questions? If we have time.
I have got one. You know, when we were talking about the mild acne, and we can use the combination of topical antibiotic with BPO and or a combination of BPO plus adapalene.
Mm-hmm.
If, for example, somebody has got mild eczema and they need to go on a topical one, can we combine a topical antibiotic with adapalene?
I can't think if there's a preparation that does that. So if you can find one, yes, but yeah.
Yeah, if we do the like two separate
you can do them separately. They generally say put them on kind of an hour apart, which is a bit of a pain. It's going to reduce compliance. So I try and get them on one preparation if you can. The other thing to bear in mind, I didn't say was when you're putting these on, is normally say put it on, give it 10 minutes, wash it off, go every other day for a bit. Because if I slap it on and leave it on overnight, then I wake up in the morning kind of burning red. So always kind of build up to it and tell them.
Yeah, and the other thing is, can we do a topical antibiotic with azelaic acid?
Yeah, you can use that as well. Yeah, I don't really like azelaic acid. I don't use it as much as benzoyl peroxide. I use it more in rosacea, really.
Okay.
If it works, go with it.
Thank you.
Ooh, seborrheic dermatitis, role of steroids versus short-course topical antifungals. I'd prefer antifungals because of the risk with the steroids in the face and things, but it's what works really is the issue. Seb derm I don't really like. It's a bit of a pain. You know, oh, that must be for another presentation about my Yorkshire puddings. It's what's working. So if they try some antifungal and it's not helping, yeah, give them some steroid. I'd avoid a combined preparation because then you don't really know what's helping, which is a really common theme. You know, Dactacort is a bit of a bane of my life because people seem to prescribe it for anything, and then it either doesn't work and we don't know why, or it does work and we don't know what's worked. So, you know, try and split them out and use something, you know, appropriate. UV lights reduce bacteria in the skin. Ooh, that sounds a bit scary. I would say no. Yeah, we know sunlight improves skin, and we know light therapy, TLR1, does make a difference. But I would argue either this UV light isn't really doing very much, or is it UVA or is it UVB? And that's going to increase their risk of skin cancer. It's like a sunbed. It's, you know, it's the suntan they're getting, particularly on the eyes. We're going to increase the risk of cataracts. And the worst, which is coming about a bit more now, is UVC. So you can buy these UVC lamps, which are germicidal. They are awful. That UVC is like, it's just bad stuff. You know, you will, if you put your arm next to the lamp, you will start to smell bacon in about 5 minutes. It's just terrible stuff. Essentially in the air, it kind of generates aerosolized bleach. It causes oxygen-free radicals, which are really bad for us, but they're great at getting rid of bugs. So yeah, keep away from those. How long can you use?
Sorry guys, just because we're running a little bit tight with time, will we be able to keep the other questions that have been raised for the end of the session?
Well, that was the end. Oh, the end of the total session. Yeah. I'll just do one last one. So combined pill, I'd say whichever pill, you know, stick with the first line ones as long as you need to, fine. Yasmin, I sometimes prescribe that and I don't worry about kind of how long. It is higher risk than the other pills. So if you can get away with, you know, kind of the first gens you might be going on, to go with that. Dianet, kind of 3 to 4 months only, and then switch back to another one. It's only licensed for something and contraception, you know, sort of acne or PCOS with contraception as an addition. I wouldn't use it on its own. I rarely use it anymore. I tend to put them on Yasmin, but the risks are fairly comparable really in terms of kind of the VTE.
That's wonderful. Thank you ever so much, Dr. Graham. That was a really, really useful chat. And I think you said the slides are going to be forwarded out to everyone, so everyone should be able to get the slides, which is great. So we are going to move swiftly on, if that's okay. We've got Mr. Steve Smith, who's going to come and have a talk to us about teenage pregnancy and options regarding teenage pregnancy. So if it's okay, I'll hand over to Mr. Smith. Thank you very much, Mark.
So it just looks like our speaker, Mr. Smith, has disconnected from the chat. He was here a moment.
He's still here.
Is he still here?
He's still in the meeting. Not sure what's going on there. Selena, can we call on you to come out of order? Because I can see that you are here. Is that going to throw you off completely?
It isn't, but I just need to log on my laptop because I'm on a different screen. Give me 2 seconds. Let me just get that up. I'll just open up the Zoom on somewhere on another computer. Annoyingly, my my emails aren't opening on my on my laptop to get my Zoom invite up. Let's try again. Oh, right. Sorry guys, I'm just trying to log on a different computer. Right. Oh, I don't know what time's coffee supposed to be. I was going to say you could, if you're all right waiting. Just going to try and sign in.
We're meant to have Mr. Smith 3-ish and then go for a coffee at about past. And then Selena, I think you're at 3:45-ish. So I don't know if we wanted to just maybe mix it up. What do you think, Tara?
Why do you, I think it's just going to take me a couple of minutes to get this because it's logged out of Zoom, so on my laptop. So do you want to maybe go for an early coffee break and then come back, and then we'll all be ready to go, and it'll save everyone some time.
Yes, if you want to have a coffee break until 3:30, and then we'll start again at 3:30, and we will hope that we can manage to locate Mr. Smith and Selena will be ready to go.
Yeah, that sounds like a good idea.
Are we taking a break now?
Yeah.
Yeah.
We're going to take a break for 10 minutes.
Yeah, that's fine.
The early coffee break.
Can I ask one thing, if you don't mind? Because I know that you are letting people in for the teaching. Will you mind if, because I'm currently logged in on the Zoom from my iPad, and I have to go and pick my son around 3:30. So if I log out and log in from my mobile while driving, so will that be okay? Somebody will be able to let me in?
Yeah, I think it's on Tara's Zoom invite, so that should be fine.
Yeah, that's fine. Yeah, thank you.
Oh, okay. Stephen, if Zoom Smith's here now, do you want me to go at my the normal time?
Well, I've been trying to get in touch with Mr. Smith, and I'm not sure if any of the others have had any success.
Well, his presentation's up on Zoom now. That's why I was wondering if he was back.
Ah, fantastic! There it is. Yeah, teenage.
Yeah. Okay.
Well, if that's the case, then Selena, would it be all right to maybe get Steve to or Dr. Smith to do his bit 30, we'll come
That would
back.
be absolutely fine, because my Zoom has just logged me out for 30 minutes. It's a bit of a disaster.
If you're okay with that, Selena, then we'll do that and then hopefully see how it is. That okay?
Yeah, because am I supposed to be at 4:15 or 4:30, 4:15 anyway? Yeah.
Yeah, it is. 3:45, I think. But we can be a bit fluid with the timings.
Okay, so we're going Mr. Smith next, and then
We've got Dr. Lund from CAMS coming
Okay, so
around.
Smith, and then Anna Lund, and then you, Selena.
Yeah.
Is that all right with you, Mr. Smith?
Oh no, not that one. Let's go back to Zoom. My goodness, what's happening today with all of our technical issues? Always the way. Right, what is going on? Right, try again. Oh, guys, it's not letting me share screen either.
We can see your screen. We can see your legal considerations.
Yeah. Oh, okay. Oh, okay. It's got. It's because I'm on different. I'm trying to be clever with my dual screens. There we go. Let me get you back here. There we go. Hurrah. Okay, we're all sorted. Right, guys. So I was just asked to talk about sort of 5 or 10 minutes around some of the legal considerations of treating sort of children and adolescents. I don't know what you find, but I personally don't think it's a problem until I come across the case that's the problem, because I think it's one of those unknown unknowns of mine. So I just thought I'd clarify legally what the situation is in England. And this is all. Can you still see the screen? It says it's suddenly paused.
Yeah, I can still.
Yeah. Okay.
Yeah.
So just looking at what the GMC guidance is, what some of the BMA guidance is. and also what some of the defence unions say as well. So in the UK, it should come as no surprise to you that a child is considered to be an adult from the age of 18. But between 16 to 18, that's the grey area, which some of us sometimes can get a bit confused about. Essentially, in England, those people between the ages of 16 to 18 may be able to make independent medical decisions. And it often depends around the sort of decision itself. Younger children, so those under the age of 18, may be able to consent depending what their capacity is. So I think the key is it's not about the age. That's not the clear indicator. The indicator is if they have the capacity to consent. So most of you will know and have heard about sort of Gillick competence. So this comes from a ruling in 1983 when Victoria Gillick took the health authority to court when she declared sort of prescribing contraception to an under 16 was illegal. Now, she sort of challenged the Department of Health guidelines around contraception advice, and they very clearly laid out sort of criteria to judge if somebody under the age of 16 has the capacity to consent to treatment. So you have to ask yourself, does that person have capacity? And Gillick competence is not just around, sort of sexual health or contraception. This is around sort of any decision making to do with a child's health. So you want to ask yourself, do they understand the decision that's been sort of broached to them? Can they retain the information that you give them? Are they able to weigh up the pros and cons around that decision making? And are they able to communicate back to you about that decision? You also want to make sure that they're aware of the indication of that decision, the risks of the decision or not sort of going ahead with that decision, and the availability of other options. So it might vary from something like, you know, do you give somebody some antibiotics for a UTI, or, you know, does that child sort of consent for an appendicitis? It obviously is decision dependent. So they might be able to consent if they take some antibiotics, but they might not be able to consent if they're going to have an appendectomy. And if they do not pass that that Gillick competence, and that's when you sort of take it to the parents, or if that's going against best interest, you might have to think about sort of legal considerations as well. Now, the Fraser guidelines, often people sort of use the two interchangeably. So the Fraser guidelines are more specifically around consent, contraception and sexual health. And the House of Lords sort of from the Gillick case concluded that treatment can be given if the child or adolescent understands the advice. They cannot be persuaded to tell the parents what they're going to do or allow you to do so. And that's likely to continue a sexual relationship with or without that contraception, and physically or mentally would suffer if that contraception or that sexual advice or contraception advice wasn't given. And you deem it's in their best interest to be given, for them to be given that treatment or advice without parental treatment. I personally don't like the word sort of cannot be persuaded to tell their parents. I think that sort of suggests that you're you know, maybe being quite heavy-handed with them, but certainly sort of discussing sort of the options with them and sort of being quite open-minded about it, because you want to encourage them to discuss it with a parent or somebody that they you know, is responsible for them. But if they sort of did obviously meet Fraser guidelines, you still give treatment or an advice. Under 13s, it won't come as a surprise to you, but they are deemed legally not able to consent to any sexual activity. And that's very much, you know, a situation where you'd report to police, social services and child protection, the child protection team. The under 16s to 17s, that's, as I said, a slightly grey area. So around consent to treatment, that differs around where you are in the UK. In England, those people of that age, it can be presumed that they have capacity. But if they refuse certain circumstances, then that might be overridden by parents, or occasionally sort of you know, legal sort of a legal court case if needed. So that might be, for example, if they make a decision which could lead to irreversible damage or lead to death. And that's what we're saying, for example, about a child who's got, the adolescent who's got a severe appendicitis who refuses sort of surgery, for example. Access to records, that's just something I sort of wanted to touch on really briefly. Because this is becoming an increasingly problem, and again I sort of feel is a bit of a grey area and something that maybe you don't always get exposure to in practice. So 15-year-old parents have asked for access to our records. What do you do? So again, sort of looking at the GMC guidance, so young people have capacity to have young people with capacity have the right to access their records. But they can also allow and prevent others access as well. And it's usually deemed that from the age of 13 onwards that they would have the capacity to consent for access to their records or gain access to the records themselves. But again, it's not age dependent, it is capacity dependent. Parents can have access to children's records if they've got consent from the young person or if that young person lacks capacity and it doesn't go against that child's best interest. But you'd obviously want to be in quite careful consideration to make sure you're not disclosing any confidential information or any sensitive information to the parents without their consent. And also if you're going to allow a young person to have access to their records, to ensure there isn't any sort of sensitive information like you would do with any sort of request for access to records. The other thing that always confused me was about parental divorce as well. So that doesn't affect parental responsibility, and both parents can still have access to records if the young person gives consent. Parental responsibility, I always remember this being an AKT question. So this relates to the legal rights and obligations for that child, and in England it extends to the age of 18. Now usually that's the child's mother, but it would also be the father if married to the mother at the time of birth. Unmarried fathers, and I think this is sometimes where we get a bit sort of stuck, because they're often quite tricky situations where you might have lots of different people involved in a family. So unmarried fathers will only have parental responsibility if the child was born after the 1st of December 2003 and their name is on the birth certificate. Now, parental responsibility might be useful, and you might need to know about that if you need to authorise treatment and consent to treatment. So, for example, things like vaccinations. So normally it's okay to have, one parent's consent. So, for example, a child comes in and needs some antibiotics, you don't need to get consent from both parents. But you might be in quite a sort of sticky situation or a difficult situation if a child, if a parent comes to you because they want their child to be circumcised, for example. So that's often the time when you need to make sure that there are both parents consenting to that. And like everything, you want to make sure that you involve the child as much as possible. So in summary, as I said, it was nice and quick. So Gillick competence is about judging the capacity to consent to treatment, whereas Fraser guidelines is specifically around contraception and sexual health. You want to assume a sort of young person is competent until proven otherwise. And again, it's about sort of assessing capacity for that particular decision and trying to involve the child and adolescent as much as possible. And if they're deemed not to have capacity, it can be given with that can be given by somebody with parental responsibility, or in a very unusual situations, sort of courts as well. But that's obviously something that you would be discussing with your sort of wider team, and trying to gain sort of parents or the child on board as much as possible before you went there. Okay. Are there any questions at all? Or?
It looks as though there's a few questions in the chat.
So that's for a child born after 2003. Where do you stand for consent if a grandparent brings a child for a vaccination or a minor treatment? That's an interesting question, and I think each practice will have their own policy about what happens if a grandparent or the nanny brings a child in for vaccination. So normally most practices have a policy to say that they would want written consent from somebody with parental responsibility. So I know our practice does that, and my practice does that I'm a patient with. So my kids went for the vaccinations and I had to send a letter to say that I was consenting for them to having the vaccinations and the nanny was bringing them. Very occasionally, you know, you might, if they sort of turn up, you might be able to sort of, you know, ring up and speak to mum on the phone, and the practice nurse might take it that way, but most of the time it needs to be written consent. If one parent agrees but dad doesn't in an urgent situation, I've heard they tend to go with the mum's decision. I'm not sure about that. I suppose at the end of the day, you'd be going with what's in the child's best interest. So if there's something that's in the child's best interest and it's an urgent decision, you would probably be going with that decision. That's certainly what sort of is written in the JMC guidance. Can a child decline consent for vaccination at the age of 14 for HPV or vice versa? Child, sorry, sorry, Fema, what have you said? Child wishes to have,
yes,
but the parents don't consent?
Yes, the child wishes to have the HPV, but the parents decline.
Is that a situation that you've had for Hema, or is that just something?
I've heard some of my family members discuss this, where they didn't want the child to have the HPV, but the child was wishing to have it, but they weren't at that age. So I wasn't sure what to advise them.
So I suppose it comes back to if the child's got capacity to make that decision and understands why they're having the vaccine, the pros and cons of having it. And I think, again, you would have to go, you know, if you felt that they did have capacity and you sort of broke them to be Gillick competent, then I think you'd be fine to go ahead and give them that vaccine. But obviously you'd want to do what you could to get the parents on board and talk to them about the reasons why they don't want to have the child to have the vaccine, and what their sort of concerns are around that. Is that okay? Okay. There's no other. So Lizzie, so young female from a religious family with a queer and ectopic, didn't want to disclose parents for religious reasons. Imagine you would do your best to override this when it's in the best interest of the child and send them in via the ambulance. The definitely get into hospital. Yeah, I mean, at the end of the day, you're, you know, the underlying thing is that you want to do whatever's best for the patient, and you know, you hope the family would as well, in terms of wanting the person to get help as sort of quickly as possible. So yeah, that it is a tricky scenario. And I think Mark said he wanted to mention a case.
So just very briefly, I had an interesting case when I was a trainee, and it's about kind of consent and things. So I had a 15-year-old girl who came in for contraception. So thinking about that, what do you want to ask? You want to know, well, who are you going to have sex with, you know, in terms of that. And it was a 16-year-old. So technically that's statutory rape because she's under 16 and he's over 16. And how do you deal with that? Because I think you need to kind of know more, I think, was the key thing. Because, you know, if she was 15 and he was 16 and he met her in the park and he plies her with drugs and alcohol and all his friends do as well, that's really okay, you know. But if he's 16 and they go to band together and they've known each other for 2 years, that seems a lot less sinister. So I think, you know, in those kind of cases, you've got to know a bit more, you know, because again, it's still illegal, but, you know, one of those sounds very bad and one of them sounds less bad. So I think it's just knowing more information and thinking more about it when you've got those kind of cases, you know, rather than just not asking the questions at all, or making a blanket no. Tara might disagree.
I love the fact that I seem to have developed this kind of role of like absolute seniority, but I completely agree. It's the key thing you've got to think about is that power differential and an age differential, and realizing that actually over the age of 14, actually, if they kind of go to school together and it is consensual, nobody is going to be interested. And the key thing is to keep them safe and avoid pregnancy, avoid STIs, and move on. But actually, you know, even if somebody is over the age of consent, arguably, actually, if they are 16 and the partner is 52 and you think they are a vulnerable 16-year-old, you can't go, oh, well, it's all fine. they're over the age of 16. So it's that nuance of actually recognizing what is potentially abuse, what is potentially something that somebody can't consent to. Even if they appear to be consenting, actually there may be some difficulties. But I'm going to stop now because I have a feeling Amy and Stephen are going to move us on.
Thank you very much, Selena. That was really helpful. We are running a little bit behind, so I just want to say to Dr. Lund, I'm really sorry. We are running a little bit late, but are we okay to go back to Mr. Smith and teenage pregnancy? Because I think we've got things working now, which is excellent. So if it's okay, I'm going to hand over to Mr. Smith and we'll crack on with this. Okay, and questions in the chat, please, if that's okay.
Can you see my slides?
Yes, we can see them. Hooray! Thank you very much for joining us, Mr. Smith.
Apologies, I'm not the best person with technology, so do forgive me. Right, I'm going to talk today about teenage pregnancy, and I'm going to share with you some data from our home termination of pregnancy service, which is one of the good news stories from the COVID situation. Now, teenage pregnancy is associated with poor outcomes for young parents and children. Teenage mothers are less likely to finish their education, and teenage mothers are more likely to bring up their children alone and in poverty. Teenage mothers also have a higher risk of mental health problems, and the infant mortality is 60% higher for babies born to teenage mothers. So the children born to teenage mothers have an increased risk of living in poverty and are more likely to have accidents and behavioural problems. Now, reducing the rate of under 18 conceptions is an ambition in the Department of Health's A Framework for Sexual Health in England. Now, between 1990 and 2017, the under 18 conception rate was decreased by 62%. In 1990, it was 47.7 per thousand. In 2017, it had dropped to 17.9 per thousand. In 2017, 51% of under 18 conceptions resulted in an abortion, and that's the highest percentage in over 25 years. Now, these statistics tend to range in the 15 to 17 age range because only 5% of under 18 conceptions are to 14 years and under. Now, the reasons for reduced rates are improved access to contraception, a shift in the aspiration of young women towards education and training, and the perception of stigma associated with being a teenage mother. Now, one of the anecdotal things that I've noticed is that I think that women nowadays who've been brought up in poverty by a young mother realise that there's better options. Now, it's some years since I had a specialist teenage pregnancy clinic at Chesterfield, and now the girls under the age of 20 are seen in the general antenatal clinics. And this is very interesting data. In the year 1st of April 2019 to the 31st of March 2020, 2,617 women gave birth at Chesterfield. There were 2,645 babies born, and only 81 of those babies were delivered by women under 20 years of age. Now, obviously, this is a superb sort of like set of figures, really, and I think that, you know, we can all say we're going in the right direction. Still, more needs to be done to prevent unwanted pregnancy, and the strategies involve better sex education for young people and promoting effective contraception, particularly long-acting reversible contraceptives. And there's been various comments about the use of those this afternoon. Another very important thing is to improve access to sexual and reproductive health services, and this includes TOP services. And that's what I kind of like want to talk about today, the improved access to TOP that's been made available since the COVID crisis. If you've only take one message from my talk today, it's discuss contraception with the young woman who decides to keep her baby. Many women who have a termination of pregnancy are very reluctant to talk about contraception. But I've found that young girls who are pregnant and have decided to continue are very keen to think about contraception. But it's a very poor service that's provided. And in an audit that I did about 10 years ago in my specialist sort of adolescent clinic, contraception was discussed in less than 5% of cases. Now, this, I think, is a very interesting slide because it shows that contraception is fallible. A lot of people think that every woman who presents for termination of pregnancy hasn't used contraception. But even those who have tried very hard can end up having an unwanted pregnancy. Now, I just want to go through some of the statistics regarding abortion in England and Wales. Now, in 2019, the total number of abortions was 207,000. Now, this is the highest since 1967, and 98% of these were under ground sea. Now, looking at those rates, you can see that the rates amongst under 18-year-olds and under 16-year-olds has decreased dramatically over the last decade. The highest rate of terminations is in the 22 years age group. Now, a lot of people are surprised when they hear that 99% of abortions are funded by the NHS, but 74% of all abortions take place in the independent sector under NHS contract. And the people who provide these services, Mary Stopes, British Pregnancy Advisory Service, and other groups, provide women with an excellent service. Now, there's been a good fall in the gestation at which terminations are carried out, and now 82% are carried out under 10 weeks gestation. Now, and I think this is particularly pertinent point for young women. The earlier a woman has a termination of pregnancy, the better, and I think that applies particularly to young women. Fortunately, only 2% of terminations now occur at 20 weeks gestation or over. One of the big good news stories has been the increase in the proportion of terminations of pregnancy that are now carried out medically. Mifepristone was licensed in 1991, but it wasn't until 2014 that there were more medical abortions than surgical. And sort of, you can see the trend there. So 2012 onwards, there's been a steady increase in the number of medical terminations that are carried out. Very few of the total number of terminations are carried out for fetal abnormality. Sort of like the vast majority are carried out basically on request. The number of terminations that are occurring for non-resident women is falling, and that is another good news story because of the improved sort of provision of termination in Northern Ireland and the Irish Republic. The termination is in the news virtually every day. This morning, when I was driving to work, I heard a news story talking about how there's plans to introduce the first termination laws into Argentina. And still, in 2020, there are 40,000 plus women in Argentina who are admitted to hospital because of errors associated with illegal termination. And no matter what anybody's position is on the moral aspects of termination, as doctors, our priority must be the protection of women's health. These are the reasons behind ground E abortions. The vast majority are performed medically. The big area of controversy in this group is that the fetal-maternal medicine doctors in the UK are pushing for the provision of surgical termination for women at higher gestations. And it seems a little sort of disjointed that it seems okay to carry out D&E, as we call it, for women who are at higher gestations with an abnormality, yet the sort of helpfulness towards those who are having a ground C termination is not as well developed. This is my favourite phrase. As a person who's always been interested in women's health, the standout phrase from my medical school was when I read this: the oral contraceptive pill has revolutionised the place of women in society. I don't know if you could put that in a book these days, but it certainly shows the opportunities that are available to women now because of contraception. When I was a medical student, in the whole of Liverpool, there was one female obstetrician. When I was a registrar, I worked in a hospital with 2 female obstetricians. Now, as a consultant, I work in a unit that has 12 consultants and 8 of them are women, and all of them have had their own children, and all of them are sort of like very committed to sort of like their professions as well, and it shows how society has moved on. Women didn't get the vote till 1918, when the Representation of the People Act gave the vote to women who were over the age of 30, who had possessions of property with a rateable value of £5 per year, or they were married to men who had property with a rateable value of £5. That act also gave the vote to all men over the age of 21. Women got equality with men and the vote at 21 with the Representation of the People Act in 1928. The Abortion Act came in 1967. The Representation of the People Act in 1969 gave the vote to 18-year-olds, and in 2006, 18-year-olds could become MPs. Now, this is the standard regime for medical termination of pregnancy up to 9 weeks and 6 days. And as you can see from this slide, the efficacy is at its best if there is a spacing between mifepristone and misoprostol. Now, misoprostol can also be given by the sublingual or buccal route, but very few women are able to hold it in position long enough to get the sort of like the best effect. And the regime certainly is most effective when the misoprostol is administered vaginally. Now, abortion doctors, such as myself, have been trying to allow women to self-administer the drugs for for termination of pregnancy at home. And in January 2011, the British Pregnancy Advisory Service went to the High Court trying to change the law to allow women to self-administer the misoprostol at home. They didn't win that sort of like court battle, but what they did to try and improve the service for women was to produce what they called the simultaneous dosing regime, which meant that the woman had the mifepristone and the misoprostol together at the same time. And as you can see from this slide, there's sort of like, it's efficacious, but the side effect rate is much greater when you give the doses together.
I'm terribly sorry to cut in, Mr. Smith. It's very, very interesting as so far. I'm just very conscious that one of our next speakers, Dr. Lund, needs to leave by 4:30.
Yeah.
Would it be possible at all?
Forward the slides to you?
Yeah, or potentially, if we could potentially restart from where you'd left off at 4:30, if that's another option as well.
Yeah, that can certainly do that. Yeah, yeah.
Yeah, just because Dr. Lund is, I think, a little bit pressed for time, and I think it will be a bit of a chat about CAMS, which would also be very useful for us registrars. So long as that's okay with you as well, Mr. Smith.
That's just fine. Yeah, yeah.
Yeah. So we'll switch over and come back to you after Dr. Lund, if that's okay.
That's good by me. Yeah.
Thank you. So apologies, it's a little bit rushed. Very, very interesting talk so far from all our speakers. Our next speaker would be Dr. Anna Lund, who's a child and adolescent psychiatrist working in CAMS, and she'd hopefully be talking to us a little bit about CAMS and how it works, etc. Dr. Lund, are you available at the moment?
I am here, yes, I am just getting the, can everyone see that? Help, I need somebody. Yep, you can all see it. Yep, smashing, okay. Hello everyone, my name's Anna. I'm one of the consultants in CAMS in Chesterfield and North Derbyshire CAMS. So I'm going to do a bit of an introduction to CAMS, whistle-stop tour, and just think about some of your red flags for CAMS and give you some links to some other information which will help you right now if you're working in GP in this area, but also will help you in the future to know how to best use your CAMS services and how to best support CAMS services developing. So let's just see if we can, oh, there we go. So I've given you some nice sunny pictures because it's a bit miserable outside and I thought we might cheer ourselves up. So what's a psychiatrist? They've done at least 8 years post-grad. 3 years will be with adults mainly, and that'll incorporate some learning disability and some forensic psychiatry. And then if they're specialising in children and adolescents, they'll have done 3 further years higher training. And most psychiatrists will have an additional training in the therapeutic modality. So for example, I'm trained in specialist trauma interventions like EMDR and also family therapy. And what you've got to think about is who or what is your CAMS provision locally. Hopefully most of you will come and work in Derbyshire with us, but if you don't, then the detail about what CAMS is locally isn't going to apply to you. You need to know because it will differ whatever area in the country. CAMS is very, very I'm trying to think of the right word. Anyway, it's been messed around over a number of years because historically there isn't a clear commissioning pathway for CAMS. So when you get your GP jobs, I would thoroughly encourage you to write to your local commissioner for your mental health lead in the CCG, so that they know that you're interested, but also so that you can find out what is commissioned. And it's always interesting, because when I did this, when I started the job in CAMS, I found out that our commissioners were paying for a few things that they didn't realise they were paying for. So that was really useful for me and for them. And if you think about the change that we've had in commissioning over the recent years, with just in the time I've been a consultant in Chesterfield, there's been at least 4 commissioners for children's mental health. So the change doesn't support long-term strategic investment. Future in mind investment is the money that people have been talking about recently in terms of CAMS provision. And CAMS provision is commissioned across numerous services, not just NHS specialist CAMS provision. So when people say CAMS, what they mean is all services that provide any mental health input to children and young people. So make sure you know who your local consultant CAMS psychiatrist. So there's me, there's 5 other consultants in our area. It might surprise you to know that in the country there are only 940 CAMS consultants, full stop. So there's 52,000 GPs, I think. So there's not very many of us, and we're not very loud, I think, at making sure that our patients get what they need for that reason. The locality here in CAMS in North Derbyshire is the only locality that I know of in about 100 miles that has a full complement of substantive consultants in CAMS. So a lot of CAMS services are run with at least 1 or 2 locum consultants. Or, unfortunately, out of 1,050 posts in the country, 100 posts are empty. So Tara, don't slap me on the hand for this, but if anybody really likes psychiatry and children, then you're very, very welcome to leave GP training and come and join us in CAMS, because I've got 100 jobs waiting. Your local CAMS psychiatrists are very likely to be isolated from the rest of the medical world, particularly when they're based in the mental health trust. So as GPs and CAMS psychiatrists, we've got a massive amount of shared interest. So it'd be really useful to get to know. And it's made a huge difference to me knowing people like Tara and knowing some of the local GPs in terms of integrating into the local population. Okay, so when do you need to ring a psychiatrist? It's kind of obvious. So when there's a risk of harm to others, if it's associated with mental health, and I always have to say that because I have had calls where someone's not mentally unwell and people say, this person's trashing the place, can you come? And I go, you maybe need to ring the police. Yeah, so associated with mental health, that's when I need to be involved. So if they're saying in person or online that they want to kill someone or displaying violent behaviours towards others, and they've got an associated underlying mental health condition like an emerging psychosis or a severe depression. If they're a risk of harm to themselves, so again, if they're saying in person or online that they want to kill themselves, if they're taking steps, collecting tablets, planning how to end it all, or doing any final acts. And with teenagers, we quite often see this posting on Facebook or Snapchat. And then the other part of risk to self is in terms of weight loss, self-neglect, which may be part of an eating disorder picture. So weight loss, which is a rapid weight loss of 1 kilogram per week, a serious neglect of self. And we've had a couple of cases recently in Derbyshire where there has been really, really severe self-neglect associated with mental health difficulties and some parental neglect as well. So that's when I want to know about them. Okay, the reason this is important is because the suicide rate in young people is rising. It's the biggest killer. There are the interventions that we offer within CAMS absolutely do change this. And I know CAMS has got a relatively poor reputation in some ways, but the outcomes that I see every day are massive, and I don't think I could do this job without getting severely unwell myself if actually people didn't get better, and that is the truth. So we need the right people at the right time. Okay, other reasons: changes in behaviour or thinking, and this is particularly thinking about things like psychosis. So if people are acting strangely or not making sense, losing touch with reality, seeing or hearing things that are not there, and becoming paranoid. And when we think more about psychosis, if we think about what our red flags are for psychosis, so it's most days for a month, and we're talking about a thought disruption. So this is thought echo, so you hear your own thoughts repeated. Thought insertion, generally characterised by someone thinking that someone is able to put thoughts inside their brain through some external mechanism. So it's often things like teenagers will say, the Americans are putting thoughts inside my head through the mobile phone. That's quite a difficult one to tease apart, because partly it's true, yeah. And if they say the Russians are, well, then I'm like, oh God, right, we're going to have to really work on this one. But obviously I'm joking, because actually that's, you know, you have to pull it apart, and you have to very carefully think about what's the current cultural context and work out whether it's a delusional belief or not. Thought withdrawal is the same mechanism, but thoughts being taken from your head by some external agency. So I had a young person a couple of years ago who believed that every time they walked past a lamppost, their thoughts were taken from their head. And then thought broadcast is what it sounds like. So they're walking around the street and they think that other people are getting a broadcast of their internal thoughts and can hear what they're saying. Other red flags: delusions of made actions or passivity. So that's the experience of really believing that someone else is making you do an action. And then delusional perception. This is things like a shape in the cloud means that God sent you a message to save the world, or delusions of reference. For example, I was watching Channel 4 News, and Jon Snow had a message for me that told me that I was the person who could save all the children in Africa. Those kinds of delusional ideas. Auditory hallucinations are very common in teenagers. They are really common in teenagers who have anxiety and depression. When we're worried about it being a first episode psychosis type of hallucination, it's usually where you've got two people talking about you and commenting on your actions. So they're your red flags for psychosis, super quick. So why ring a psychiatrist? They can actually be helpful. We need to know about serious crisis emergency presentations and serious mental health conditions. Intervention works, and if we don't intervene, there's a massive mortality and morbidity impact. What works best? So our treatments, both psychological and medical, in terms of psychopharmacology mainly, work really well for first episode psychosis. They also work really well for depression and anxiety conditions, PTSD and OCD, and eating disorders. Okay, so what to do, what to know. We've talked about who's your local CAMHS provision, what's the crisis number, how do I talk to the on-call duty worker consultant? Because when you're in surgery at 6:55 at night and a teenager comes in and says, I want to die, I want to kill myself, you need to know who to ring. So, picture of the dog, because it's all a bit depressing, and that's Mimi. Luckily, she hasn't barked yet. So, CAMHS, just a brief summary of what the whole provision of CAMHS is. Your Tier 4 provision is your inpatient provision. Locally, we don't have a unit in Derbyshire. Our nearest unit is at Nottingham. And you will be aware through the news that there's a huge delay and a huge lack of capacity in CAMHS inpatient beds, which is a combination of factors. One, that there isn't enough inpatient beds, and two, that there isn't enough community provision to intervene early enough to prevent people needing inpatient beds. So the government strategy is currently supposed to be working on both of those things, although because of COVID, what's happened is that any of the extra investment has kind of been soaked up with the increased morbidity of COVID. So in the local area, you've got your tier 3 provision, which is your specialist CAMS. So this is what everyone traditionally thinks of as CAMS. And in Chesterfield and North Derbyshire, it's provided by Chesterfield Royal. In South Derbyshire, it's provided by Derbyshire Healthcare Foundation Trust. And specialist CAMS are there to deal with moderate to severe mental health difficulties. In some areas, they will also be commissioned for all neurodevelopmental difficulties, so autism spectrum disorder and ADHD, but locally that commissioning lies with paediatrics, both in the south and the north. And then you've got your tier 2 provision, which is for mild to moderate mental health difficulties, and locally that's provided by Build Sound Minds, and that's provided by Action for Children as the provider. And then your tier 1 is everything else, so basically primary care, schools, youth workers. Information. So the best source of information locally is the new Derby and Derbyshire Emotional Health and Wellbeing website. This is kept up to date by the CCG and has been a massive piece of work, contains information for parents, carers, young people and professionals, and that's got all the links to all of the mental health support services locally for children and adults. So that's something to have on your favourites. And then the thing that you need to know at 6:55 in surgery when someone says, I want to kill myself, is the contact number for North Derbyshire Urgent Care Team. And that's the team that works with me. That's recently been commissioned in the last 2 years. So they provide urgent assessments within an hour to young people who are presenting with serious suicidal thoughts or following serious acts of self-harm. And that's the end. Okay, so if anyone's in South Derbyshire, I'm not sure if they are. Tara, could you just give me a nod if they are, if anyone's in South Derbyshire? No. Okay. So any questions quickly before Mr. Smith comes back on?
I have one question.
Yes.
You said that anybody that needs who needs to be referred has got associated mental health problem. But for example, if somebody is hasn't got like diagnosed mental health problem, but surely they are having psychosis. So should we be able to contact you then?
So sorry. So if they've got symptoms suggestive of psychosis.
Yes, but they don't have any diagnosed mental health problem.
Most people you refer won't have a diagnosed mental health problem, will they? Because they won't have been seen by us yet.
Yeah.
So so the example is in terms of people who are presenting with serious violence or serious violent risk to other people. Yeah. But there has to be enough to suggest that there's a mental health difficulty. So you know, so
like from previous like history from the parents and
history from the parents or history about what you're seeing in clinic. So you may be seeing someone who is really distracted, disturbed, who tells you that they're hearing voices.
Yeah.
Then that absolutely would be someone.
If there is enough evidence of mental health problem, then they, even if it's the first encounter, you can refer that patient to you. Yeah.
Absolutely. So it's not about someone having a diagnosed mental health condition. It's about having clear mental health symptoms.
Yeah. Got it. Thank you.
Yeah.
Hi, I've got a couple. Sorry, Dr. Love, I've got a couple of really quick questions, if that's okay. Apologies if I missed this at the start of the presentation. What's your age limit with CAMS? Is it 16, 18, somewhere in between? 18.
But that will change on the different areas. So Sheffield have a half and half, where if people are in the service, they'll carry on up until 18, but if people present after 16, they get referred to adults. Whereas in Derbyshire, we've kept it hopefully clearer where it's 18. Problematic transition though, and the evidence base suggests that actually we should be looking after people until probably 21, because actually you've got massive amount of frontal lobe development until 21. And we're asking, all right.
That's great. And just really quickly, you said that anybody with a risk of self-harm, i.e., teenager comes in and says they want to kill themselves. Obviously, if we refer to the crisis team every time an adult said that to us, you'd be overwhelmed. So obviously, there's a bit of kind of getting more information there and trying to weigh that up in terms of what steps they've taken. So would you say you'd have a lower threshold if a child said they wanted to kill themselves as opposed to an adult? Does that make sense?
It does make sense, Helen. Yes, I think you've got a different threshold in some ways. I think what you've got to remember is that thresholds are very driven by commissioning and provision. Yeah. So if we had adequate provision within adult and child services, actually there wouldn't be a threshold about, oh, they'll be overwhelmed, I won't refer them, because there'd be adequate provision. However, it goes without saying that you're going to do your own assessment. So if someone comes in and says, I feel like killing myself, and you go, tell me what's going on, yeah? And by the end of the conversation, they're going, God, that was a daft thing to say, and actually, thank you so much. I don't really feel like killing myself now. You're not going to refer them. The situations I'm talking about are when actually you've done all the stuff that you can do as a GP, and you're still thinking, I'm not very happy with this young person walking out of my consulting room. So what you're going to do is safeguard them. So you're going to, with their agreement, talk to someone who can help support them and keep them safe, like a parent. Or if the parent's not that good and there's reasons why that's not helpful, somebody else. And you're going to ring the crisis, the CAMHS crisis team. So the criteria for CAMHS crisis team are serious suicidal thoughts and severe self-harm, and they do act very much as a crisis team, so it's there and then intervention. And if someone isn't presenting with that level of severity, then it would be seen within a kind of normal CAMHS provision.
Thank you very much.
Sorry, can I just ask, in terms of you talking about obviously there's only 900 consultants, are there any sort of GPs with a specialist interest in CAMHS? Do they exist?
They do. In fact, GPs with a specialist interest do exist, but I don't know of any who are working as that.
Right. Okay.
I do know of a number of GPs who are working as specialty doctors within CAMHS, and in fact, in our local CAMHS service, one of our specialty doctors is a GP. She's qualified GP, and she worked in GP for a number of years. That's Jackie Thomas. If you want to get any further information about that, because just in case you want to come and work in CAMHS. Sorry, Tara.
Well, you could be a gypsy and still work in GP.
And if you were open at any point to hosting an innovative training post in CAMHS, which is where they spend half their time in GP, half their time with you guys, and they get paid for by the GP side, but
very interested.
Doctor. Well, I'll message you later, Anna, because I suspect that there may be some of this lot that might be quite up for that.
Excellent, Tara. Thank you.
Oh, yes, please.
Can I just make a point, which I suppose, when we think about young people and adolescents in particular, is I sometimes think it's worth thinking, when you start thinking about neurobiology and brain biology, just remembering that the impulse control of the average teenager is not dissimilar to that of a 2 or a 3-year-old.
Indeed.
But a 2 or a 3-year-old, you can strap in a buggy. You can hold their hand. You can make sure they're always with a babysitter. The thing that makes teenagers really scary and makes teenagers die is that they make impulsive decisions to do stuff, and they don't have that sort of frontal lobe calming effect. So it's all crazy. If you're into Steve Peters' chimp paradox, it's very chimp driven. So the teenager that actually is risky, got to think about those, who have persistent thoughts, but also it's remembering that teenagers do sudden, really silly things really urgently, really quickly, and they're big. So actually, where a 3-year-old can be prevented from running into the road by us picking them up, unfortunately, lots of 17, 18-year-olds have driving licenses, have access to alcohol and friends and railway bridges and all sorts of other things. And that is what makes looking after teenagers so very different to adults, because they just don't have that impulse control, which generally speaking we grow into, but not until the age of 25 or 26.
Yeah, indeed. I'll come and do another talk for you on the teenage brain and that kind of stuff. But it's really worth remembering that actually your provisions about risk mitigation, and it's not what I'm talking about today, but just to be helpful, if you are in surgery at 6:55, actually you're acting in the best interests. If they're saying, I don't want you to share this information with my parents, well, from my point of view, it's tough. you know, because actually my most important thing is to keep you alive. So I do all the talk about trying to support them and let's do it a different way and who can we do it and all the rest of it. But essentially, if they're presenting with massive risk, then actually I need someone else to be involved in helping support them, as I would do for someone over 18, but particularly as you would do for someone who is still a child. And I think we have to remember that even though they might come in, they might be working, they might present as really sorted, they're still a child with, as Tara said, a developing brain and absolutely developing frontal lobe. So the other tips are, with parents, you need to make sure that all parents have got all their medicines locked away. There's still so many people who don't lock away their tablets. So most of the teenagers that I see have taken an overdose of paracetamol that they've got from the bathroom cupboard. You know, and if that was just a bit harder, they wouldn't have taken the overdose of paracetamol. You know, so those kinds of things. You know, as risk mitigation. And remember that as much as we try, we can't get rid of all risk, and it is about risk management, and that's why it's useful to have people like a crisis team and people like a consultant psychiatrist who, I'm used to doing this and I can help you with it. But also, Helen's quite right that if you ring me about everybody, then I'll completely burn out and, you know, I'll go and work in Tesco's. But you know who you're going to ring about, because you're going to do your best to manage it beforehand, and the ones you really can't, you're going to be like, actually, we need some help with this one.
All right. Hello, Hannah.
Hello.
Yeah, thanks for the talk. Just a quick one. Now, in a young person that presents with psychosis secondary to substance misuse, so do we generally refer directly to substance misuse service, or do they come through you? And in such cases, do you get involved at any point?
Yeah, so the commissioning locally in Derbyshire is for under 18 substance misuse is through Change, Grow, Live. So if a young person has, so it depends on the level of the psychotic experience. So if they've got off their head on MDMA and they've had some hallucinations which have resolved within a few hours, Change, Grow, Live. Yeah. If they have had persistent hallucinatory experiences despite stopping using drugs for 2 weeks, then that's going to be under 18, it's going to be CAMS, and then if appropriate, we'll get the early intervention service involved. If it's clear psychosis, you can refer to early intervention straight away, but it gets a little bit complicated if I was going to cover all of that today. You're best to go to the information sites, because it tells you who to do when.
Okay, thank you.
Brilliant. I think I speak for everyone when I say that was really useful. So thank you very much for that, Dr. Lund. And apologies that it was just a little bit late in starting.
No worries. I've just got to go on a home visit. That's all. All right. Thanks so much. See you soon.
Thank you very much, Dr. Lund. And is Mr. Steve Smith still around?
Yeah, I'm still here. If you can hear me.
Fantastic. Apologies that it's a little bit of a fragmented talk. I realise that it's coming up to 5-ish. Would you still be happy giving a very quick talk through the rest of your presentation?
I'll literally be. Can you see my slides? Can you see my slides?
No.
Can you see my slides? No?
Not yet.
Oh, yeah, we've got them.
Yes, you've got them now.
Yeah, I'll quickly. So I quickly told you about the EPS attempt to introduce sort of like self-administration of misoprostol in 2011. We it's sort of like that slowly came in over the next few years. That the simultaneous dosing regime, and we introduced it in Chesterfield in 2018. Now, an MP called Diana Johnson, a Labour MP from Hull, tried to produce a sort of like a 10-minute rule bill, which is basically a private members bill to sort of decriminalise abortion in 2018 October. But this got bogged down because of the Brexit situation at the time. It's quite interesting when you dig down into the opinions of the heavily Brexiteer supporters, the European Research Group. It's very difficult to actually identify who they are, but the European Research Group sent a letter to the then Prime Minister Theresa May in February 2018. There were 62 signatures of that letter. Only 2 voted in favour of the bill, no voted against it, and the rest abstained. One was a no teller. It's just, again, very low percentage of MPs actually voted in that piece of legislation. Should have had a second reading in November, but that didn't go ahead because of Brexit impasse. So things looked like they were sort of like stagnating on that, but then in December that year, the Secretary of State for Health and Social Care approved home administration of misoprostol for women up to 9 weeks and 6 days, which allowed women to have the mifepristone in a licensed unit and then take the misoprostol home and self-administer it. And sort of like, and a lot of places started to do that straight away. The good news that came out of Brexit, of COVID for women, was that because of the COVID restrictions introduced during lockdown, in March of this year, the Secretary of State for Health and Social Care approved 2 temporary measures. Women could take both treatments for medical abortion at home up to 10 weeks gestation, and doctors could actually prescribe these from their home. So, like a lot of you places, we jumped onto this very quickly and started doing it straight away. And I just quickly want to share you the data from the lockdown. During the lockdown, we had 135 women who underwent a home medical termination of pregnancy. That's, i.e., they had a sort of like a telephone consultation, remote prescription of the drugs. The drugs were sent out of the home by a courier. They self-administered the mifepristone, and then under instructions, they self-administered the misoprostol. We managed to get hold of the data from 132 women. Now, the average age of this group was 28.5, which is a bit higher than the group that we're talking about today. But as I said in my earlier slides, the incidence of pregnancy in younger people is gladly going down. Sort of like last year also at Chesterfield, we sort of like introduced a self-referral system to the termination service, and as you can see from this, the time that women are being sort of having the consultations when they're self-referred is a lot quicker than when they're coming through general practice. And we're hoping that sort of like this is going to be good for young girls and improve their access to the termination service. That's just the methods that we used for our audit, which was basically sort of like going through the computer systems of the hospital. Our success rate was very good. We only had 1 failure out of 132 patients. The retained products of conception rate was a little bit higher than we would like, but those who actually required intervention were only 4.5%. The rest were managed conservatively. And that's just a quick demonstration of the 3 ways of dealing with retained products conception. So the message that I wanted to give today was that sort of like from the COVID crisis has come a very, very good thing for women, in that the long-awaited self-administration of the drugs at home is now going ahead, and it's been shown to be an effective and valuable option for many women. Our audits only hunted small. BPS, Mary Stropes have literally done audits of thousands and have got very similar results. We've got a very good working self-referral system now to the termination of pregnancy service at Chesterfield, and we hope that this will benefit younger girls, because if younger girls can get to the service quickly, they can have the terminations earlier on when it's more safe, and we won't have any sort of serious consequences. The major downside that people would say about lack of face-to-face consultations, particularly amongst younger women, is it leads to lower opportunities to deliver effective contraceptive advice. But as I said in my earlier slide, many women are reluctant to discuss contraception at the point of termination. Now, that whether that's because they're dealing with a specialty doctor rather than somebody who they see as more generally based, I don't know. But you know, that again is an area that sort of like perhaps general practice needs to take up. And that's it. So I'll quickly finish for you. Hello?
Thank you very much, Mr. Smith. That was brilliant. Sorry we had a bit of a delay, but thank you for coming back to us. I really appreciate it.
Amy, I'm not very good with technology, I'm afraid.
No, it's fine. It was lovely to have you here. Thank you for putting that together for us.
Good.
Does anyone have any questions for Mr. Smith?
I have one. Oh. Sorry, I've got one, if that's okay. Yeah, in terms of this, I think you said there was a 60% mortality rate in the babies of these teenage mums. Do we know why, apart from the fact that they're young women?
Well, again, this data is you know, that data is now data that's getting old. But sort of like young women are more likely to have premature babies. That, you know, they're more likely to have concealed pregnancies. They're more likely to have sort of like less effective antenatal care. And in the past, that was associated with the poorer outcomes associated with teenage pregnancy. But sort of now the numbers are improving so greatly. I think that sort of like, you know, hopefully in the future, those girls that do have teenage pregnancy, the infant mortality rate is going to be better.
Can I ask if people come to see us, should we then be advising them to refer themselves, or should we be doing the referral?
Well, this is always a very interesting point because, you know, obviously the person who's got the long-term care of the woman is the general practitioner, and best practice is always, in my view, when you know, specialist services are provided. You know when there's cooperation between general practice and specialty doctors. Unfortunately, because of the stigma that still surrounds women's choice to have a termination of pregnancy, there's a lot of young girls who don't want their GP to know. Their auntie might be the sort of like the HCA at the practice, the auntie's friend might be the receptionist. You know, there's a lot of young girls feel that their secrets are being revealed in general practice. And I think that for a lot of young girls, the option to self-refer should be made available to them. So I think a ready availability of that pathway should be there. But if it was my daughter, I would personally prefer that she have a chat with a GP before she went for termination.
Yeah, that makes sense. Thank you.
Mr. Smith, do you think that we're going to be able to keep the service, or there'll be enough evidence for it to continue post-COVID whenever that happens? Or is there any, the home sort of treatment service, is there any chance of that changes in terms of what we tell women when if they do consult with us about having termination?
Yeah, I think there's the perfect storm is developing in favour of you know, this kind of service now. The results are absolutely excellent in terms of sort of like this service. Unfortunately, as in all systems, you'll get abuse of it, and we have had one case where a male using a female associate tried to access the service, and he wished to obtain the drugs to produce an illegal termination abortion for his partner. Now, fortunately, the scheme was discovered, and sort of like and police action was taken, and the person is now charged. So you know, you're always going to get a minority of people who will abuse a very, very good service. But I think that the data from sort of like the NHS and from the sort of the independent providers is now so good. I think that sort of like the government is going to have to change the law. I'm pretty certain of that.
Mr. Smith, what's the sort of age limit that you would be prepared to offer a teenager a TOP, providing that she was sort of Fraser and Gillett competent? Would you sort of draw the line under a certain age?
Well, again, Amy, that's an excellent question. And again, it's sort of like it all revolves around best practice. I mean, if I saw a girl of any age with an unwanted pregnancy, you know, then you would wish to sort of like provide that young girl with the opportunity not to be pregnant. Now, when fortunately the numbers below the age of 15 are extremely small, as I said in my slide earlier, only 5% of teenage pregnancies are below 15 years of age, and the numbers of teenage pregnancies, as I said before, are now low anyway. If somebody was 13, 12, they presented with their mother, and you know the partner was of a similar age, I think that all parties would be try to deal with that situation as sympathetically as possible. I mean, the dilemma that I face mainly is the mature Fraser/Gillett competent girl of 15 who is adamant that she doesn't want her mother or guardian to be told of what's going ahead. And I think under those circumstances, if you've satisfied yourself that you know that it was a consensual activity, her partner is of a similar age, it's very difficult under those circumstances to force her to inform her parents. Mm-hmm. But of course, you know, we would involve social workers, etc.
Yeah. Can I just ask, have you ever had to make a child a ward of the state or arrange for that to happen?
I haven't, no. It's sort of like I've been involved in a number of cases, only one at Chesterfield, but certainly several when I used to be an abortion surgeon for the British Pregnancy Advisory Service, where the material removed at the termination process has been taken as police evidence when the you know the sort of like it's been deemed that an illegal and non-consensual act has gone ahead, and genetic fingerprinting has gone on to you know ascertain the parentage. So that's kind of like the involvement that I've had.
I think that might be it in terms of questions, unless anyone else has any last minute ones.
Good. Well, thank you very much for inviting me, Amy. I greatly appreciate the opportunity to speak to you.
Oh, thank you so much for coming. It was lovely to have you here. Thank you.
Bye. Bye-bye.
Thanks. Bye.
Thank you.
So that concludes our day, everybody. Thank you very much for listening. Sorry we had a little bit of reorganisation, but we got there in the end. I don't know if you wanted to say any final words, Tara, or anything.
Well, yeah, an enormous thank you to Amy and Stephen and Greg for today, and I think it's gone really well, and you have handled the technical stress of Zoom with aplomb, because it is always really stressful, and I've been sitting here thinking, oh man, and thinking, no, but it's not even me that's in charge today, so that's been a really lovely feeling, and I'm very proud of the way that you guys have done that, really impressive. So yeah, I'm thoroughly looking forward to next week's second session, even if I do have to be a responsible grown up and present a bit of it. So yeah, thanks very, very much, guys. if anybody's got any feedback, that would be really helpful. If you want to put it in the chat, if you've got anything, particularly any learning points that you've got from today that you think are really worth having made. And if not, we'll see you next time. If you haven't RSVP'd for next time and you want to come, please do, because as I say, the one downside of Zoom is it's 100. We rarely ever get up to 100, but I know we were pushing 100 at a couple of points with some people who hadn't said they were coming and then did. And don't forget to click the Survey Monkey to say that you were here. And otherwise, lovely to see everybody, and we'll see you next week.
Could you post the survey